I am a medical student here at Emory, and I'm the education chair this year for HealthStat. I'm very excited about it. This is one of our biggest events of the year. We're going to talk about and celebrate all the great work students have been doing across Georgia and try to get people excited to do something next year for our community. I'm going to turn it over to our president of HealthStat, Jenny, who's going to kind of talk about what HealthStat is and what we do.
Thank you. Good morning, everybody, and welcome to our Student Leadership Symposium here at HealthStat. This is one of our longest running events, so we're thrilled that you're all here to share the great work that you're doing across the state and engage with each other in meaningful discussions about work that's helping to build a healthier Georgia. For how many of you, this is your first HealthStat event? Oh, good. Okay, great. Well, welcome again to HealthStat. For those of you who may be a little bit less familiar, HealthStat is a student-run nonprofit organization. We're interdisciplinary and statewide here in Georgia, and we have a big two-part mission. The first part is to empower students, health professional students as leaders and advocates, and the second is to build a healthier Georgia through service, education, and advocacy. And we've been around for a little more than a decade now. And so we've really done a lot of growing, and we're looking forward to more continued growth and doing more good work in the community. And this event falls under our education arm, where we're really working to share with our peers and colleagues and work to engage and empower each other. We also have advocacy, which we're really well known for. We do a lot of work with access to care in particular, and advocating for Grady and other institutions that we partner with. And in our service arm, some of you may have participated in Step In for Health or Street Medicine or Cut Hypertension. We have our chair people here in the room today, so if you have questions about those programs, we definitely invite you to ask and get involved, because there's lots of different ways to stay connected with HealthStat throughout the year. Definitely want to thank you all for being here. How many folks do we have here from Emory? Probably quite a few. How about Morehouse? Welcome. Georgia State. Excellent. Mercer. Hey, welcome. Are you from the Macon campus? Awesome. For those of you who don't know, we did start a HealthStat chapter in Macon this year, which was something new and huge and exciting. So thank you for making the trip to Atlanta. We're so thrilled to have you here. How about UGA? Any other schools that I missed? I know. Where are you from?
From Life University out in Marietta.
Life University, welcome. Thrilled to have you here. Okay, so how many public health students? Awesome. Nursing students? That's me. Yay. How about medicine? Awesome. PA? ET? MBA? You have some MBA folks. PhD? Got a few PhD folks? Anyone I missed? Okay, well, thanks for being here again, for joining us. I want to recognize Ashley for all the hard work that she's done to organize this symposium. So thank you, and we're thrilled again. And to recognize all of our board members, raise your hand if you're on the HealthStat board. So feel free to come and approach us at any point, ask any questions that you have. I also want to introduce Alita Donover in the back room. She'll be the incoming president effective on May 1st, so she looks forward to continuing to work with you throughout the year. And just one thing I'll mention, we do have one upcoming event that you have flyers for at your table. We have a panel discussion on Monday, April 20th, where we're going to be diving into some professional issues that are affecting access to care here in Georgia. We have an excellent interdisciplinary panel. We'll be having this event at Mercy Care, which is one of our partners that we work with, particularly through the Street Medicine program. We'd love to have you there and to chat with us and have an open and meaningful discussion about what we can do to foster interdisciplinary collaboration and make sure that we can address access to care issues here in Georgia. So I won't delay us any further, but again, welcome. We're thrilled to have you, and we hope to see you at HealthStat events moving forward. All right, we're actually running early, which is good because people like to talk, which is wonderful. So we're excited about these topics. So if you're okay with Ellen, we're going to start with you. I hope you're okay. We are. And we're going to start a little early, but
is Caitlin Allen. She's a second-year public health student over at Rollins, which is the Emory Public Health School, great school. And she's actually going to be presenting her thesis studies and findings to us today, which is really exciting. So I'm sure a lot of work. Then we're going to learn about the integration of community health workers into care teams and prevention management.
So just being I present for 40 minutes.
You
all hear me okay? So thank you so much for having me here today. I have actually said I will be presenting part of my thesis findings on this presentation. Was cut down from about 40 minutes worth of content. So I think that this presentation also fits in really nicely with the ideas about access to care and addressing health disparities, particularly through advocating for community health workers, which is a very unique workforce nationally and also in Georgia. Before I begin in earnest, I'd like to dedicate this presentation to Dr. David Callahan. He was a physician at Emory and on my thesis committee. He passed away very suddenly in the winter of this year, and so I just wanted to recognize and honor his memory and work. So really quickly, we will be going through the context of who community health workers are and what their roles are in high blood pressure, self-management, and medication adherence. I'll talk briefly about two of my research questions, my methods, results, and of course, future directions. So how many of you have heard of or know about community health workers? Great. So this is the APHA definition of community health workers, and I point out that they are frontline public health workers, and they're trusted members of the community that they serve, and they help to facilitate access to services and improve the quality and cultural competence of service delivery. But there's so much more than just this definition. They really take their background and life experience into their job setting. And when I started doing research with community health workers at CAC, I felt like in the literature they were a little bit hidden. When I was reading things, we talked a lot about this workforce, but not a lot to them. And so this work was really intended to give community health workers a voice and showcase their perspectives about their work. Another important kind of contextual piece is that I noticed is that we know a lot about the input. So the community health worker is the input, and then that arrow is this process, and we know, which we don't know a ton about, like what's going on in the interactions between community health workers and their patients or clients. The literature tells us that they are effective in addressing high blood pressure and adherence and other health outcomes, but it's like there's some magic going on. It's like there's some magic going on, right, in that process that community health workers are doing. And so I wanted to help uncover that sort of magic. So I did this through the context of high blood pressure, and I'll be referring to high blood pressure and hypertension interchangeably. And I wanted to learn more about what community health workers were doing in chronic disease through high blood pressure, because it leads to so many detrimental health outcomes like cardiovascular disease, stroke, myocardial infarction. It's also extremely prevalent in the United States. 1/3 of the US population has high blood pressure, and it's also very expensive. There are clear disparities, again, in hypertension outcomes. And we see this by race, we see this by socioeconomic status. And so what a better workforce to be addressing the high blood pressure disparities and issues than community health workers who are really from the communities that are underserved or have these disparities. I use two theoretical frameworks, which is a very public health and behavioral science thing to do, but I'll get into those in more detail once we get to the research questions. So here are two out of my 4 research questions, which these two focus on the self-management aspects of high blood pressure and then specifically the medication adherence aspects as well. Methodologically, what I did was conduct a national level survey and I also then conducted 23 qualitative interviews. So my survey took place for 2 months, as well as my interviews. I pilot tested it with community health workers, it was online, and then my interviews were all over the phone. They were transcribed verbatim and then coded with 2 coders. And I felt like it was really important to have mixed methods because the whole point of this was to give community health workers a voice, right? So we needed to literally hear their voices through that qualitative piece. So here are my results. Over 400 people actually clicked on the survey link, and it was posted all over the country, which was really great to see. I had 265 community health workers who consented to take the survey, and you can see that about 2/3 work with high blood pressure, and then 40% are working specifically with medication adherence. And then, as I said before, I interviewed 23 of them. My demographics for the survey align really closely with other national level community health worker surveys. You can see here that this group of individuals is very well educated, with most of them having some sort of post-high school degree. Furthermore, I really reached the sample that I was focused on, which were community health workers in a healthcare sort of setting. So you can see that about 26% are working in community-based organizations, but combined, about almost half are working in some sort of healthcare organization, and those were 12 people. So to talk about hypertension self-management a little bit more in detail, CHWs are working with patients for an average of 7 months out of the year. And they are going and meeting with their patients for about 2 times per week for an average of 7.8 times per month. And during these visits, they're working with patients for 40 minutes, and that's almost 3 times as long as most providers have to work with their patients or clients. During these interactions take place in the clinical setting and also in an in-home setting. And I think it's really important for us to recognize that CHWs can be in people's homes and really help to address issues of, or this community health worker talks about being able to build credibility and working with populations that have typically been victimized and have issues with trust. And so going into a patient's home and sitting and talking with them for those 40 minutes twice a week is really effective in understanding issues that patients or clients have. CHWs are working with a variety of healthcare providers, including nurses and doctors, as well as other community health workers. They are doing a lot of health education, which is no surprise. When they're working with patients, they're they're being really creative in their work. And this community health worker talks about how she used this old IV bag, and because she recognized that people weren't reading brochures or flyers about high blood pressure. So she filled this IV bag with food coloring, and then talked about how this is the blood that comes through your body, and used the orange to show the size of the heart, and just kind of very simple sort of health education. My next piece was focused on the medication adherence piece, and I decided to focus on medication adherence because the literature tells us that about 50% of people stop taking their high blood pressure medication within 1 year of being prescribed, and then an additional 85 to 90% stop taking it within 5 years. So there's a really big issue with adherence, and the medication adherence model tells us that there are 5 interacting components of adherence. And so I looked through each of these components, but just for time's sake, I'll go through just a couple of examples. So patient-related barriers are what you would think, forgetting to take your medications, having issues getting them refilled, and things like that. And so community health workers identify patient-related barriers as being an issue for the people that they work with. One CHW talked about a very simple intervention that she did with the patient, which was just moving his medicine box right next to where he brushes his teeth. And she knew to do this because she went into his home and talked to him and realized that that was a barrier that he had, a very simple and effective Condition-related barriers are typically focused on having multiple health conditions, and so CHWs identified this, that people have more than one health issue, and that because of that, they're confused about taking their medicines. And it's not surprising that diabetes and obesity and those sort of conditions are also occurring when you see high blood pressure. But I think really interestingly, depression and anxiety and mental health were identified as being other conditions that people have for their when they have high blood pressure. And I'll give you this example as well, which is that a community health worker was in a patient's home and they realized, she was talking to her patient, and she had this toolbox with all of the medicines that she took and her daughters took. And so just every time she needed to get medication would go into the box and pull it out. And obviously this was not a very effective way to go about things. And so she worked with her and helped to put together a pill box, and that was really effective for her. So I know I'm almost out of time, but I will say that one thing that continues to come through the community health worker interviews and surveys was that CHWs are working in partnership with vulnerable populations. They are, what this community health worker says it beautifully. She said, you don't make any decisions for the patient, but rather help them with goals and help them to stay focused. CHWs might be working with blood pressure, but then branch into social issues that people have. They are truly advocates, and this CHW says that our goal is not to shame them. Our goal is to make sure that they have the information that they need to make good decisions. So my work really helped to give us this process piece of what CHWs are doing when they're interacting with patients. And just as a teaser, the other half of my work looked at the environment in which CHWs are working. So what sort of healthcare systems are they working in, and how are they integrated into those healthcare systems? What support do they need? And I think, again, with all of that information about healthcare systems and what they're doing within the context of their organization, the most important thing that CHW said is that they need to stay part of the community, because that's really their strength. And so if they can maintain their community connection either by staying engaged in community service or with other CHWs, it really helps them to target the most vulnerable populations. And I think this also is really an important work because we have such a focus on patient-centered medical homes, and there's this healthcare environment which allows for CHWs to be integrated into healthcare teams. And CHWs recognize this, especially in the Affordable Care Act, that it helps them to do their job better. That's all I have for you, and I would be happy to take any questions for a couple of minutes. Thank you so much.
Could you speak a little bit about the training that goes into becoming CHW and also funding?
Sure.
You mentioned the ACA. Is that helping?
Yeah, so the training piece is really interesting. It varies drastically from state to state and organization to organization. I asked community health workers if they felt like they were well trained to be doing their work. And you can see on this slide here that most of them agree or strongly agree that they are pretty well trained to do their work. But then if you get more specific into like hypertension issues, or I guess generally chronic disease type issues, they didn't feel as well trained. And so training could take place, like for example, in Massachusetts, they have a statewide curriculum and you become a certified community health worker. But in Georgia, for example, that doesn't exist. So if you become a community health worker, you're trained at your organization, however they deem necessary. So that is very, very different from place to place. For funding mechanisms, the ACA very explicitly mentions community health workers in the write-up, and there are opportunities through the Center for Medicaid and Medicare Innovation to be writing grants and things like that for funding CHWs. The CDC has a ton of grant opportunities, And CMS just came out with a rule change which allows for community health workers to be delivering health education services under the provider. And so people are working on how to fill that and go about actually. Yes.
So you mentioned that that the survey was available all over the nation. So wondering, do you see any there's like striking differences between how health care community health care workers conceive of their role in communities one side of the nation versus the other?
I didn't see so much like, north, south, east, west sort of divides, but I did see the divisions by type of organization, right? So like here I mentioned, but here I show you just a little sample of where they're working. So CHWs that were working in more of a community-based setting felt more integrated because their superiors bought into the idea of community health workers, whereas, and like FQHCs also, because they understand the community needs a little bit more, whereas a large hospital system, they weren't feeling as well integrated or had as great of training because they are in such a large organization. So I would say state by state, I saw the differences, but anecdotally, I know that they exist. It's a more viable organization. FQHC, federally qualified health center.
A lot of people wanted,
Yeah.
is that reflective of healthy workers?
So my demographics are very reflective of national data that we have. There was a survey from the University of Arizona that was of 1,500 CHWs, and they conducted it over a year and had a census. So my little survey is actually almost exactly parallel to demographics of CHWs. Predominantly female, which kind of makes sense since it's such a healthy field. But yeah, interesting demographic.
Thank you so much.
Well, great talk. I mean, obviously, it's unrealistic to expect things that are so insidious. Critical, I think this is the way to help with fix all of this. So thank you so much. People here from the medical education. Good. I'm glad. I get nervous. And all of the fringes over there. Sorry, let me set up your presentation here as I talk about you guys. So basically, this is super exciting as well. This is the only state-led group in the country. Services we provide to patients. They train undergraduate and graduate students in volunteer medical caregivers in statewide clinics. So I think this is something we can get involved in too. Yeah. All right. Sorry, you guys have to introduce yourselves. All right, well, thank you for the introduction. We're really excited to be here and share our project with you, our organization, and we're excited that you're all here to listen. I'm Kristen Allen.
I'm Tel Rodriguez, and I'm in the nursing school.
I'm Christina Request, and I'm Rollins Public Health student.
Okay.
Okay, so we are MA University's Volunteer Medical Education Services. Our case place is in healthcare. So basically, our main premise is helping to improve health disparities. We wanted to start out. Yeah. So we wanted to start out talking a little bit about the population and basically give a basis for why we do review and how we started. So As some of you might know, the Hispanic population in Florida and in general in the United States faces a lot of different health disparities. They're a hugely growing population. Previously, statistics about them growing. The majority of which are, not the majority, but a large percentage of which are uninsured. They're the highest uninsured rate. They have the highest uninsured rate of all racial and ethnic groups in Georgia. Again, the Georgia immigration laws also discourage a lot of Hispanics to pursue medical treatment because of their status as far as application and other areas. Also, huge amount of poverty and they also have a higher prevalence of chronic conditions. And then where we kind of come in a little bit more is the language barrier requirement. So the language barrier is a huge obstacle for the Hispanic population. There's, even though we are in southern states and there are a lot more people that do speak Spanish, that still is a barrier. It's a fear of them that they won't be able to properly convey their health conditions, their symptoms, how they're feeling, and then the provider won't be able to, or will provide information that they don't understand. It's not really English. That's kind of where it is.
I'm going to speak over here because the majority of people over here are kind of opposite side. Okay, so with this huge increase in the Hispanic population, there's also kind of a risk for poor communication between the provider and the Spanish-speaking patient. I'm going to give you guys kind of a little story, a little example of what can happen when there's not a trained interpreter. And so in Florida, there was an 18-year-old who was brought to the hospital with his kind of a community clinic with his family and some of his friends, and he only spoke Spanish. And so they were just saying, you know, intoxicado, intoxicado. And what would you guys think that means in English? Intoxicated, right? Which in English would kind of mean, you know, little drugs and alcohol kind of overdose maybe. And so he was kind of treated for drugs and alcohol when he actually had an intracerebral hemorrhage. And if there was a trained interpreter, they would have known that that kind of meant poison. And they thought he was poisoned. They thought he had food poisoning, so they would have looked more into it. But they kind of just thought it was drugs and alcohol. He didn't receive the care he needed, and he was left quadriplegic. And that is just one example of when, you know, interpretation isn't available, what can happen. And so there's these 5 Emory students that kind of saw a need for trained interpreters all over Georgia. They saw a need, especially for clinics that had low resources they didn't have money kind of to pay for the interpreters. And they would normally just use Pullman med students or actually any volunteer that kind of speak un poquito español, which kind of isn't enough for the medical setting. And so they wanted to create an organization where they would place undergraduate and graduate students who were trained in interpreting as volunteer medical interpreters. They're going to kind of tell you how to do that.
All right, so since the inception of UMIS, our organization has helped provide care to over 630 patients through the Emory School of Medicine, Good Samaritan Clinic, the Migrant Farmers Project, and many other collaborative events. So our training program is the result of a partnership between Emory University, Grady Memorial Hospital, and Good Samaritan Clinic, and also Culture Connect, which is a local nonprofit. Our training program consists of a classroom portion as well as a kind of clinical exposure portion. And then this culminates in a certificate of proficiency, which is accredited by the International Medical Interpretation Association. After our interpreters receive the certificate and go through their practical portion, they're able to interpret at the Emory Good Samaritan School of Medicine Clinic, where we provide 100% of the Spanish interpretation needs. A few of the other
organizations that we work with, the Mexican consulate with their Bienvenidos de Salud program, the Hispanic Health Coalition of Georgia, their Feria de Salud, and then we also have 2 great faculty advisors who provide great support to us. A little bit more about some other events that we do. We work, as I said, Good Samaritan Clinic, where we provide all the Spanish interpretation needs. We also train our interpreters there. With the training of our new classes, we work with Culture Connect, the local nonprofit. We partner with the School of Medicine, or no, the nursing school, and the PA school for the Georgia Farm Workers Project. We're going to go to Southern Georgia, bring in a bunch of students and interpreters, and deliver care to migrant farm workers who otherwise wouldn't have any care. We work with the Mexican consulate, the Bienvenidos de Salud program, and also with the School of Medicine, OSCEs, social medicine OSCEs. So that's objective, structured, clinical examination. So we work with them, and it's kind of a partnership where we provide experience what it's like being an interpreter. They provide experience to students about what it's like working with an interpreter, and then we go through some patient-provider simulations.
So a little bit about how you can become an interpreter. Because we want to have the best interpreters that we can find in the Emory University undergraduate graduate campuses. We have kind of a large process of picking those people. So you have to be proficient in Spanish, but that's only one of the many different things that you kind of need to be an interpreter in general. They have to be driven as well and have a passion for working with this population and a number of other things. So we have an online application. We have in-person interviews after that. Then they have a Spanish proficiency test to make sure that they have their Spanish up to the level, which is provided, or which is done by Culture Connect again, the local nonprofit. And then after that, after passing all those parts, then they start the Culture Connect course. So the Culture Connect course is 48 hours of in-class, like an in-class course basically, which is held on Saturdays between 9 and 6 p.m. So it's a big commitment. It's really big commitment. So that happens over 6 weeks. Then they have a final with Culture Connect. They pass that, and then they start their practical component. So as I'm sure a lot of you know, just being in a classroom and learning about medicine or learning about nursing is not the same as actually doing it. So we thought interpreting is exactly the same way. So we have a kind of like a gradient, I guess, of the practical part of it. First, we shadow another interpreter. Then they have their own. They interpret, but they're supervised by a trainer. And then afterwards, they have one unsupervised where they go in and they do all of the interpretation, and then they come out and can ask questions or talk, and then there's always somebody there to kind of provide support. We just redid our whole practicum part of the training component to focus more on peer mentorship a little bit more. So instead of having trainers as grading, we didn't necessarily have an affiliation with BMIS prior to that. We decided to have our own interpreters who already graduated from the program, had plenty of experience, go back and actually be the trainers as well. So it promotes peer mentoring as well as just more cohesion between the group as a whole, creating that kind of community. So that's kind of the trainers part. We also focus a lot on mentorship and professionalism, sort of that development in general. The Leadership Club, for example, which we 3 of us are a part of as well as 3 other individuals, work a lot with the professionalism and mentorship part of it. So and the trainers sort of does the same thing. So it's a lot of just a lot of advice giving and any of the younger or less trained, I guess, interpreters can always come to anyone on the leadership board, talk about anything. We as interpreters, we deal with the same clinical experiences that doctors and nurses also deal with. So there's us situations that we have to interpret for, and there's a lot of noise going on. So it's a big component as well, is that kind of community building as well. Okay, so just last semester, I'll do the first part. We're proud of our successes. So just last semester, we had, so just in the fall, 4 months, we had a total of 180 hours that we contributed for 49 patients. Right now, we have 29 currently active members, so we have 74 total in BMIS as a whole.
And there are 29 currently active members, and 74 since BMI started, and total, and 726 patients. It was kind of really exciting for us since we did only start in 2011. So, you know, getting up there, getting more opportunities, more interpreters, and we're really excited. Okay, so sorry. So now, kind of, you know, interpreting is a very like solo thing. You kind of go in there with the clinician and you're kind of by yourself. But we also try to promote, you know, kind of cohesiveness between our group. And we have this banner, it's a very colorful banner with a lot of handprints that says BMIS. We kind of started this tradition where they would kind of leave their mark.
Yeah, so notice that there are only slightly fewer patients that would do your work than you have hours. So that comes out to like an hour per patient. So it isn't, when you use interpret all that experience, although we were together once. And do they tend to take a long?
They do, because there's, if you think about it, it's like the, you know, the provider has to go through me, and then to her, and then to me, and then to her, and it takes longer. That's why, you know, it's great that we do OSCEs and stuff, because, you know, we're working with future doctors, and we kind of help them understand how to work with an interpreter better, and how an interpreter can work with a provider better. So it is kind of a team effort, but it does take longer, especially sometimes in the kind of under-resourced clinics, because things just kind of take longer, especially if they're seeing med students. There's also some training that the med student is doing with the doctor, so it's a lot of training and stuff. So unfortunately, it does take longer, but
Yeah, and especially even at like the Migrant Farmers Project, I was in an encounter that was like 2 hours long. So it really varies, and especially when it's with medical students, going back to talk to the doctor and consult takes quite a bit more.
I was wondering if you have any like success stories or kind of information from the provider's perspective, so like how they view this program. Well, let's see. As far as the provider's perspective, is so when the best thing I can do was when 3 of us actually went to Bainbridge, and it was part of the Migrant Farmers, and we were actually like literally in the middle of like sort of a field. And so we had like, you know, those like camp chairs and all those things. So there were some people there that were volunteering that weren't trained interpreters, and then we also had the 4 of us and other trained interpreters as well. And I remember talking to the head of that program, like at the end of that day in particular, and she said, and I was like, man, we're just like going, like we just go from one patient to the next, And I was like looking around, and some of the other interpreters weren't moving as fast. And I was like, and she said that we were being requested specifically because we had that training and because we knew kind of where people stand and where, you know, that everything needs to be interpreted. And, you know, there's just certain like nuances that are very, very important in interpretation. And that's why we kept being requested, because we were being requested specifically because we had that knowledge.
It's little things that can make a difference, just standing behind the provider so that the patient and the provider can make eye contact. It's little things like that that really helps the interpretation, which trained interpreters really know. And also kind of advocate for the patient, like saying, you know, I don't think the patient is really understanding what you're saying to understand kind of the patient
body language or culture, you can understand that, okay, he's just saying yes, but he doesn't understand. So that can also advocate for the mental health provider then, like, okay, well, let me rephrase this, and let me try to come with this in a different angle. Those little things really make a difference between the patient and
Another note on trained interpreters versus just native speakers. I thought the training course was hard. I'm not a native speaker, so it was pretty difficult for me. But our newest class is almost all native speakers. And one of them noted, like, this is hard because it's a lot of terminology that you don't know, and it's just a lot that goes into it that you don't even think of. So the being a trained interpreter is really important, and it's not easy. It's not as easy as just speaking Spanish.
Either way.
Go ahead.
Okay, since y'all have had such great success with your Spanish translation services, have you thought about in the future expanding it other languages? Absolutely. You really that's our goal. That's our goal. Especially Portuguese and American. I'm like, oh, I really speak Portuguese.
You're like,
It's like, so we're trying to expand, but we are new, so it kind of takes time. We didn't want to take on too much because we want to provide quality or quantity. But yeah, we're excited. So excited.
Have you encountered any resistance on the part of the patient in having additional people involved in their medical visit? And if so, what sort of strategies do you have to mitigate that?
I can talk a little bit about that. So what we do in order to help with that, because we always want the patient to be comfortable. That's kind of our role in a way, is so that they're comfortable, they know that they're getting the help that they need. So in the training part, and as well most of the training part, because we have that extra supervising person, what we do is we have a pre-session with both the provider and with the patient, and just explain, this is what we're here for. And if Kristen, for example, was my supervisor, I would explain that she was my supervisor. Is that okay that she's in there? We check it first with the patient and with the provider as well. Maybe the provider doesn't want, a bunch of people in their way. We also make sure that because of our positioning, we stand in a way that we're not in any way in the middle of, because we're kind of just a conduit of language, of knowledge, and we try to stand in a way that we're like kind of hidden a little bit behind the patient or behind the provider. But yeah, so we do try to mitigate that a little bit by talking to the patient ahead of time, saying, you don't want this person to be here anytime.
There are also some patients that kind of say, oh, I don't need an interpreter. And then they'll try to speak English, and you'll be there. But I'm just going to be here just in case you need me, And they will know kind of like throughout the position that they need. And so, great, because I can come in and interpret. But, some patients kind of feel bad and they feel like a burden. And they feel like, oh, it's okay, I'm going to God. I'm just going to be here in case you need me. Because you don't want to force yourself, but you know that their English may not be enough to understand kind of like their medical situation. So we try to support them.
So I actually did the multi-phase farm worker as a grad student in nursing, and I have to say that I don't think I realized how important interpreters were until I did the program, and it was an eye-opening experience, and a lot of the little nuances I agree. We don't think about it as providers when we actually experience it, and you're talking to a patient, and you're just like, well, I don't think I understood that, and having the interpreter there, we didn't have enough of you there, let's just put it that way. It was a wonderful experience. But going off of the other languages that you're doing here, so you mentioned Portuguese. Is there a need you see for other languages? I know Spanish, there's a huge need, but are there other languages that you see more of the need for? I mean, Portuguese is number one, but that's kind of the, in general, that population is really what we serve with those, I guess, and because of the, like in the very first slide, the growing number of it. But I mean, other languages that we've seen is like Korean, we've seen, Mandarin and Chinese actually is also a growing language. Creole is actually huge as well, probably up there with Spanish as well. There's just a lot of Haitian immigrants that are coming I mean, we would love to expand, as much as we possibly can. But one of the huge challenges that we face is we're like kind of a hybrid between like a student-run group and also a nonprofit. So it's because we provide these services, we are all volunteers, but we also want to tap into the student resources that we have here at Emory. So we're kind of a hybrid between the two. So it makes it a little bit more challenging.
I think our next steps to expand the other language would be to do a needs assessment, to really look at what is the highest need for the next.
I guess that was my question. Is there something like, oh,
shift this projector if possible. That might be possible. Sorry, it's hot. It's not in here, but I think the air is kicked on, so bear with us. So basically, now we have another great talk from a medical student here at Emory, third year, Byron Crow. He's president of Emory chapter of the Institute for Health Improvement in Schools, an international quality improvement patient safety interest organizations for students and professionals. Last year, he and other students from IHI Open School partnered with Good Samaritan Health Center, SAM as we call it here at Emory, and West Atlanta as student-led quality improvement to better care for low-income diabetics and their families in Atlanta. This year, Good SAM Diabetes Improvement Team includes 4 students, 3 medical students, and is advised by Dr. Nathan Spell, Chief Quality Officer at Emory University Hospital. I'll have to pull up for you guys. Come on up, Byron.
Great, so thanks again, Ashley, and thanks again to the whole staff for letting me come and tell you a little bit about the work we've been doing with SAM for the past year, and really talk about today the complexity of diabetes care and the need for quality improvements and address not only the processes of diabetes, but help reduce disparities in diabetes care, especially around race-based differences in diabetes diagnosis and process issues. So, we're going to yeah, so if you were like me and skipped school anytime in the mid-2000s, you remember Wilfred Brimley as the old convention to UCLG to manage your diabetes. Well, UCLG if you're a Medicare beneficiary. And you always called it diabetes. For a long time, Wilfred Brimley was the face of diabetes to me. I, as a high school student, thought diabetes was a bunch of older, angry white guys in sweatpants. That was diabetes. Then I graduated high school, and I went to college. And in college, I was a biochemistry major. Does anyone know what this is? Anyone recognize this? Yeah, so we got some science. So as a biochemistry major, you get really good at drawing glucose sugar. You get very good at it, which is very not good for your daily life, but you learn glucose really well. And I learned in college that diabetes was from too much glucose. And it had very little to do with sweatness. When I went to medical school, I started thinking about diabetes in a new way, as a disease process, something that affects your organs. Sugar builds up in your blood and attacks your kidneys. Or it attacks your eyes, your retina, you end up losing your vision. For some diabetics, they get something called diabetic neuropathy. It attacks the nerves in their feet, you lose sensation. Eventually, you can develop small cuts, they become infected, they don't heal, they turn into ulcers, and you end up with amputation. In fact, diabetes is the #1 cause of all of these things in adults. The #1 cause of adult blindness, the #1 cause of chronic kidney disease, the #1 cause of non-traumatic lower limb amputation. But most diabetics don't die from these. They end up dying from either a stroke or a heart attack, because if you're a diabetic, the risk of having a stroke and heart attack are 2 to 4 times that of a non-diabetic patient. So that was the first year I had in medical school. Now in the 3rd year, I think about diabetes and yet another patient. That's my patients. But the hard truth is that my patients aren't all affected by diabetes. For my white patients, they have about a 7% chance of having diabetes. For my black patients, it's about a 1 in 5 chance. White patients have the lowest death rate by race in diabetes. For black patients, they're almost 2.5 times more likely to die from their disease. They're also much more likely to suffer complications than the average, almost double the rate of foot amputations in Black diabetics compared with the national average. And then, among all these other issues, access to care compounds the problem. White patients are about 15% uninsurance rate as of 2011. But these data have changed a little bit. But for a Hispanic patient who comes into my office has a staggering 41% chance of being uninsured. So this is Good Sam, located in West Atlanta. It's a large community safety net. We see about 15,000 patient encounters every year for medical reasons. All their patients are 200%, have incomes 200% below the federal poverty line, which for a family of two is about $32,000 a year. They're predominantly Black and Latino, and they generally have limited health literacy. So Good Sam is on the front lines of reducing healthcare disparities around diabetes. They are treating the most at-risk populations. But diabetes care is very challenging, no matter where you live. And to illustrate the challenges surrounding diabetes, I want you to imagine a second that you're a patient going to Good Sam. You're going to come to me. You are a Latino patient, recent immigrant from Mexico, say 5 years ago. You're a little hesitant about coming to the clinic because not all of your documentation might be good. So you're a little scared to even access the system, but you do something wrong. Because for the last month, you've been very thirsty, you've been drinking a lot all the time. You peeing, waking up at night 5, 6, 7 times to go to bed. You were tired all the time. Even though you were really hungry, you ate a lot more than normal. And you had no idea what was going on. But me, having gone through the first 2 years of medical school, and taking my board exams, exactly what's going on. This is a classic presentation of type 2 diabetes. All I have to do in the clinic, because you're having symptoms, is take a little blood draw. I just have to prick your finger. And literally in seconds, I have an answer. Blood sugar's 280, and I can diagnose you right there on the spot with diabetes. Very slow. Okay, so you have diabetes. Now what happens? Well, the care plan for a new diabetic is actually fairly complicated. Let's start with treatment. Your life's about to change a lot because now you have to start taking a new drug. You are taking one before. Almost everybody who is diagnosed with diabetes is going to start taking metformin. Metformin is pretty well tolerated, reduces your blood sugar, but about a quarter of patients end up getting really nasty GI symptoms, a lot of diarrhea. Not only that, but we're going to ask you to make some lifestyle changes. We want you to try and lose about 7% of your body weight. You get 150 minutes of exercise every week. Something moderate intensity, go out, brisk walk. And oh yeah, put yourself on a low carb diet, I'm sure. Then management, you've got to go start seeing the doctor more. You're going to have to come to the doctor at least twice a year. Each time you come, we're going to check the hemoglobin A1C, we're going to measure your blood sugar. We're also going to draw cholesterol once a year. Make you pee in a cup, test your urine for kidney damage, also annually. Then on top of your regular primary care visits, you have to go see an ophthalmologist to do a dilated eye exam so we can make sure that diabetes isn't affecting your eyes. Someone has to check your feet, make sure you don't have sensory damage, and then we'll do a blood pressure at every visit. That's pretty straightforward. This is the bare minimum. This is what happens for anybody who's diagnosed with diabetes, and this is the baseline. It only gets more complex from there. So you do all this, but your diabetes still isn't under control, so sorry, you're probably going to end up on these. That adds a whole new level of complexity to your care. Because with insulin, you can monitor your blood glucose at home. That means buying a glucometer, buying test strips, buying lancets. You got to go call Wilford Brimley, figure out how you're going to check your blood sugar next to your private list. Not only that, but you have to get comfortable injecting yourself with insulin every week. Has anyone ever given themselves a shot? I have. One person. Yeah, right? Kind of foreign concept. But don't mess it up, because if you do, you'll get hypoglycemic and go into a coma. So, when you turn 40, we'll almost certainly put you on a statin to control your cholesterol and reduce your risk of heart disease. 70% of patients with diabetes by the time they get to middle age are also hypertensive, so we're going to put you on a few blood pressure medications, probably more than one. You get diabetic retinopathy, we're going to send you to the eye doctor, and they're going to shoot lasers in your eyes, and process a procedure we call photocoagulation. If you get a foot ulcer, we're going to send you to the podiatrist so they can clean your teeth. If your kidneys get damaged, we'll put you on dialysis, maybe give you a transplant. This stuff is hard. This isn't something, worst case scenario. This goes on every day for many, many of our patients. And it's challenging to even do it for one person. But it's also more challenging to do it at scale. In the United States, we have 21 million patients who have diagnosed diabetes. Another 8 million don't even know they have. So how do we do it? Just the basics. If you look at a commercially insured patient population, in the previous year, a study showed that 17% did not have hemoglobin A1C, the most fundamental test. No one had checked their blood sugar. About a quarter had no eye exam, 40% had no cholesterol lipids drawn, and 15% had a physical exam. A similar study in France looking at these same core components found that it was present in only 31% of patients. This stuff is challenging, and our health system really isn't designed from a process standpoint to get patients the care they need. It was really easy for me to make that last slide after being in med school for 2 years. It probably took me 5 years. It's easy to make a plan. It's hard to implement. So in quality improvement, we have this paradigm, structure plus process. In the United States, we have a pretty good structure, right? We have lots of clinics, pretty well established, they're nice, they're in good standing. It's really nice, pretty good. We have great providers, we go through a ton of training, and we work hard. We want to help people. That's one of the benefits. We have medical laboratories that can run any tests you want for all kinds of crazy stuff, and we have unbelievable technology. Like I said earlier, we shoot lasers in your eyes. That's really cool. But our processes of care, once we've made this plan, are not very good at actually delivering it. So it's easy for a provider to say, hey, go get this test, but insurance doesn't cover it. And someone has to be keeping track of all the tests and treatments that you're getting and organize them. Someone has to help you organize it. So while we have the structure, our process breaks down. And when our process breaks down, we're never going to get the outcomes we want, which are lower blood glucose, ultimately fewer complications, and reduced mortality. So this is where quality improvement comes in. Quality improvement is a formal approach thinking about the analysis of complex systems. It's a way to make complex systems better. And at Good Sam, one of the ways we're using quality improvement is to improve the process. They have the structure. Now, we want to improve their process so that we can generate better outcomes for this diabetic population. So we have 2 projects right now. The first is to improve the process for tracking their diabetics. At Good Sam, if you have a patient who has hemoglobin A1C of 11, do they know that? No, they probably don't. And that's not just a Good Sam problem, that's true across the health system. So we want to identify a way, or develop a way to identify these patients who actually need help. People whose blood sugars are way out of control, but who haven't had the right tests done that they need to do here. Because once we have that knowledge, we can then develop a process in the clinic to close those gaps in care. We can call or somehow reach out to patients who have blood sugars. We can develop things like flags in the electronic medical record, close gaps in care. There are a lot of different ways to approach it. It's changing the process. And we also want to develop a standardized resource for new diagnosis. We saw how complicated it was when you get diagnosed with diabetes to do all the things that you need. We just want to have something that answers common questions for patients. You have diabetes, what do you do now? What boxes do you need to check? And we think it's a way that can help organize patients and providers around common goals. But in a meaningful way, not just saying, here's a piece of paper, see you later. But we think of it, or we're thinking of it right now, as something called the diabetes passport. A way for patients to use a shared resource, bring it required, and start ticking off these different gaps. And an important distinction is that when we do quality improvement, when we improve process, we're not doing research, we're implementing. We want to go into Good Sam and make things different after we apply. Change the way that they do their work. But we couldn't do any of this without a team. This year we really have a fantastic team. So at the top are our two project coordinators, Zoe and Emily, who are both here today in the back. You can head up out of We also have two medical students, Austin Hancock and Ronnie Conlon with us. We have two other MPH students, John Pack, who's also here, and Olivia Hopkins. And I'm there at the bottom, Dr. Spell, our advisor. And of course, we couldn't do this without the wonderful staff at Good Sam who welcomed us into the clinic and really been willing to let us try and help them do the great work that they do. So reducing diabetes disparities is challenging work, particularly the waste project. But we hope that through our project, we work with students, we can play a meaningful role in reducing the impact of disparities on the patients who are most disproportionately affected by diabetes. So with that, I appreciate it, and thank you. I'm sure I remember.
No, you're good.
No.
Questions?
Can you speak specifically about what is on this passport and the success you've seen so far? I know, and one of the clinics I work in, sometimes people will forget to bring their glucose monitors, and it's all about patient compliance, kind of one of the things we saw before. But are your patients like the system? Do they fill out the passport? Kind of what results you have?
Sure. So I'll speak a little bit about some national experience, and then I'll speak specifically about where we are. So the national experience has been that there are some resources to do kind of diabetes passport type thing, and in very qualitative reports, they've been well received. There's a team out of Chicago, I think, that have good experience, they didn't elaborate on it, and we're still trying to figure that out. As far as our experience, we just spent the last 4 weeks in the getting to know you development stage with this new team and with Sam, and really asking them what they wanted to work on. And they were very adamant about developing some kind of standard resource process for new diagnosis. So we don't have a written out diabetes passport. That's all going to take place in the next month. And when we have those results, we'll be happy to share them. I'm looking forward to it. I want to know. It may work. It may not. Either way, we'll learn something.
You very briefly mentioned diet change as one of the things that gets assigned to new diabetics. What kind of resources are currently available to them to help in that process?
So Good Sam is really good about helping their patients with diet change. They have a nutritionist on staff full time. They have a teaching kitchen that's pretty decked out, where they teach diabetes groups. They do diabetes group visits in the teaching kitchen, show people how to make healthy meals and make healthy choices. They also have diabetes group visits more regularly that address those dietary concerns. They do have this new thing. It's the urban garden. The urban farm behind Good Sam. And the doctors are trying to get to a point where they can write prescriptions for vegetables for patients, picked straight from the garden. But diet's tough. I mean, it's easy to tell people how to cook healthy. It's a lot harder to change habits at home. Just like we talked about structured process, the process in the home is that's where we don't have the structure.
I obviously presented on community health workers, so that's going to be my question. But I'm curious if you thought about ways to integrate the community members and patients into these sorts of efforts and having them become trained to work with the passport or work in the community garden and things like that.
Definitely. So not addressing diabetes, but addressing pre-diabetes. So patients at increased risk for developing diabetes in the next 5 years. There is a large trial called the Diabetes Prevention Program, which is highly trained health educators to help reduce diabetes. It's very successful. But since then, they've shown that that program was just as successful when you just use community health care. So we are really trying to figure out who we can partner with, not just in the community, but with our patients to implement some of these things. I think that's going to really hinge on how much of that structural aspect we want to develop. We feel like we need to, or it would be a good thing to have groups of diabetic patients come together and do peer support around exercising. That might be something we want to build out, but we haven't quite gotten there yet. But it's certainly something we can do.
Thanks so much. That's great. I mean, it's making Sam already in good work. Even better. I'm very excited. The next group, switching over a little bit, but as we switch over, I'm going to introduce Dr. Williams, who's here, who's an employee with the Fulton County Department of Health and Wellness, Division of Health Promotion, and member of the Diabetes Prevention Team, community business volunteers. Her background is product marketing. And then we've got Dr. Lucy Hyde, who is founder and CEO of Ruby Diabetes, a healthcare company focused on improving quality of life for individuals living with chronic diseases. You're an MD and PhD in pharmacology. Welcome. You good? All right.
Thanks for having us. I feel like we've stuck in here for this presentation, so I appreciate that. We have, in my day job, at Bernie, diabetes subteam. We have great experience having an PhD intern with us who holds thanks again. So, talking a little bit about how diabetes is
As Ashley said, my background is photography, and I'm usually the one behind the camera, but I'm the supervision experience in this there with me. This chart is diabetes in our community. Prevalence of diabetes is increasing across our state. The darker red areas here show the highest prevalence category tracked by the CDC. Between 2000 and 2010, diabetes prevalence increased 43% in Georgia. $29 million and growing. Nationally, this is growing problem of immense proportion. 1 in 10 adults worldwide are estimated to have diabetes by 2030. 1 in 3 U.S. adults have diabetes, will have diabetes in 2050. Such a large problem inevitably attracts attention funding and many separate parallel efforts to address it. The problem is that all of the organizations working towards the same goal of reducing diabetes prevalence and or improving management do not necessarily speak to one another. Okay, too large to solve alone. Collective impact brings people together in a structured way to achieve social change. That means agreeing to track progress in the same way, which allows for continuous improvement. Mutually reinforcing activities that mean coordinating collective efforts to maximize the end result. A strong backbone is a group dedicated to orchestrating the work of the group.
So this collective impact model is how we can structure the diabetes prevention. And I'll do school again, but it's a great model for something like diabetes. Because it's really predictive diabetes in the Atlantic community. You couldn't list all the organizations that touch that somehow. Not-for-profits, academic institutions, just one, Morehouse, Mercer, for-profit companies with my own that are working on technology and diabetes management. And what we realized is we all started having conversations was we were working in this together. And we all were using skill sets there around us, and together we could probably have a bigger impact on aspect than we can separately. And so I'm not going to read through all of this, but this talks a little bit about this collective impact model and what the benefits are of getting diverse organizations behind a single goal. And so for us, the diabetes prevention design is to come back to an organization. And what this looks like is we get together monthly. There in the first 50 members actively associated, probably 10 to 15 organizations show up. And our goal is not to be this official diabetes prevention. And we don't want to do that. We don't want to be the group that gets together and have meetings. Our goal was how can we actually have a community in sort of in short order. It's here's my calendar. All right, there we go. And so this is how this is run. We've been at this for about 18 months. And it really started with a conversation with two people, myself, Carla, Nazira, who works with Carla at the health department, saying, is there something here that we all want to do together to impact IBD? We can't do alone in our jobs. So this represents all different groups that we're working with. We work with folks at the School of Public Health, and engaging folks at the business school here. We have after-school programs, we have faith-based organizations, we have local media company, public broadcasting is also working with us. And so we all got together and we said, we all care about diabetes. Easy enough. It is a huge problem. So what are we going to do? What piece of diabetes do we think we can impact in the greater Atlanta community as a group? And so Nazira brought to us this model that CDC has created of diabetes. It's called Rapid model. And so onset is represented by the faucet. And the more open the faucet is, the water's coming in. That's the increased onset diabetes in the community. Prevalence is how full is that? That's the 29 million Americans. And then the outflow is death. The only piece of this that we've effectively impacted and addressed is the death rate. So we decrease the death rate due to diabetes in the long term. It's not that we were complications. It's not a huge impact. We haven't approved that. So the problem is, that's a good thing, except it takes it out. If we don't turn the faucet off, but we plug the drain, it doesn't really solve the overall problem. So as we looked at this as a group and said, okay, that's not good, because if we take out the community, the projections, how we diabetes, we're not making any progress towards reducing that number. So we really need to look at the inflow. And we put some great programs, a lot of people focus on the national diabetes program, the biggest one. There's an announcement by CDC, the American Medical Association earlier this year, renewed emphasis and focus on prediabetes and the national diabetes prevention program. That's great, it's also a little too late, right? By the time you have prediabetes, you develop some habits, most likely, that are really hard to do. And all that behavior change with reducing the behavior stuff, that is really, really hard. Go lose some body weight, exercise. And so we as a group said, well, maybe we should back up. How can we get to people before they form habits that are increasing their risk of diabetes? So we said, who's focusing on kids and their risk of becoming an adult who has prediabetes? So that teenager, or that adolescent who has prediabetes, unfortunately that's happening more and more. It's the mother of 3 young children, right? I hate this statistic. And I tell my kids this all the time. Like 1 in 3 of you and your friends will have diabetes. That's awful. But then I actually have to explain to them that's probably not true. Because you're my kids. And so if we go to another place, another school in Atlanta, like half of those kids will have diabetes. And maybe only 1 in 4 of you and your friends will have diabetes. It's complex concept to explain. I keep telling them maybe. And so we as a group decided maybe that's where we can focus. And is anybody else really talking about that message of habits as children? the connection to childhood obesity. A lot of people are talking about childhood obesity, but are people making the connection prior to obesity? And we looked a lot at the smoking campaigns. When I was a kid, that was the, in the school system, don't smoke, your government told your parents not to smoke. And the smoking message wasn't, don't smoke because it smells bad, because it's cheap, yellow. It was, don't smoke because you will die. You will die of lung cancer and emphysema. And so we said, well, our kids get the message from childhood obesity. They're getting the bullying message, Strong for Life, they did a great provocative campaign around stop bullying and childhood obesity, and how the conversation started. But are they connecting dots? Those kids work with their families. What really matters is not like cardiovascular of developing bigger needs than how they found that there was a gap there. So our mission is to reduce the prevalence of diabetes among children through education policy systems and environmental change. And so one thing we did then is we engaged a group of students in school public health schools for activity assessment. We said it's fine for all of us to think this is going to be a community, to do a person every time, but we should actually only keep trying to and so they did, and it was a fabulous report that they came back to us with. And they confirmed that there's a lack of type 2 diabetes knowledge among children, and that they don't use recommendations for how that should be addressed. So it should primarily be addressed in the school system. There are constraints, a lot of time constraints, teaching, tests, and all of them. Challenges that exist, especially in the public school system, around what time is being dedicated to core elements of the curriculum versus things like health. But fundamentally, that this is the place to engage children and to make some practical steps, like creating food as a reward, using gardens in schools, but also to develop the curriculum. We really want to use kids as a conduit to get into their household and how to take the conversation up as well. So that's one of the challenges. And we were being ambitious and saying we're going to go out and just do something automatically. So we sort of confirmed the thing that we took the Fulton County diabetes prevalence data and went to school districts that have a high strength of diabetes. Because really our target audience are kids who live in a household that has a family member with diabetes. Because they have a genetic predisposition and genetic moderate factors that have big industries that need to be cared for. So let's talk to them about diabetes in their household. And we'll take this video through, we'll get all this great footage, and we're talking about the problem, and nothing gets recorded. They can name a family member who had it. They sugar, it's pressure, it's symptom. And that helps a lot that these families not talking about it. Because we do, like one of the so it's good to have some scientific approach and then so where does this all lead us? So we just covered this need in the school system, in the community. And I'm sure you all spent a long time all summer having fun with saw each other with friends and posting it to Twitter and doing that daily exercise. So we said, what can we learn from how they engage social media and start a conversation? And if you notice, that was one of the recommendations, was to use technology and engage kids. So we said, first we've got to get their attention. We've got to start a conversation of what's diabetes, how it's affecting us, and be a little bit in front of your face about this is what it's like. And then once we get people engaged, I'll talk about next week. So this is our sort of pilot public service announcement that we produced earlier this year, and it will launch in the fall of the system.
I have my father's eyes. I have my mother's mouth. I have my grandfather's name. Do you know what else I could get from my family? Type 2 diabetes. In general, if you have type 2 diabetes, the risk of your child getting it is 1 in 7. If both your parents have type 2 diabetes, the child's risk is 1 in 2. 79 million Americans have prediabetes. Many of them will go on to develop type 2 diabetes within 5 years if they don't change their habits. Well, it stops now. I will be the change. I will be the change. We will be the change. With small changes, I can change the future. For me, for us and my family. It stops with me, will it stop with you? I have my father's eyes. I have my mother's mouth. I have my grandfather's stare. Do you know what else I could get from my family? Type 2. Type 2. Type 2. In general, if you have
So, what I'll tell you about that. Actually, I agree with many things I can do. And we're trying to get at the fact that this doesn't happen. Right? It doesn't happen. It's inevitable. It happens in the community. That's, yeah, there's nothing I can do about it. So that's part of the sentiment we're trying to get. And so that starts the conversation. You know, this will, we're working on this again. That's the start of getting kids talking about this, so they're talking to parents about this, and there'll be a video competition around that of the videos about change their making of their life, change their families, making friends, their challenge, making change stuff. I'm gonna skip the video on it. What's your what change do you do? The second piece of this is to give schools the tools that they need in order to talk about levies and so Nazira, who couldn't be here today. I don't see her on the screen, so I don't think that. But her quote was, these things we talk about, lifestyle, health, you know, fitness, exercise, are all the same things for diabetes that we talk to kids about, but we never say they're diabetes. So we've gone out nationally, organizations down here, to look for, because they invested in this in the US. So they created curriculums in the school system to talk to kids about diabetes, what it is, what the risks are, why it matters. And they all say the words about diabetes, but they all say the words about eat healthy and move forward, but nobody actually says the word diabetes anywhere. So that's what we're currently working on right now, is developing a curriculum, and we're probably going to get this organization Hatch to customize their curriculum for diabetes specifically. We will provide that to school systems as part of a resource that they have to talk to kids about diabetes. So our goal is to reach 20,000 children in the Atlantic area and to create some and to wrap up the first how that's going to happen, one thing that we do is to get involved in the summer, education, fall, so we'll launch the campaign and then and then we're just going to spring it is going to outgo the process. And we really will see the impact it is a culture that we open up. So we will choose three of the worst schools as we want to look at what works in different settings. So we will have to do some degree of watching the same way. Schools that are doing that, we have similar here in the schools. Something still. Yeah, and the great thing for our partnership model is the especially
What ways can you get involved with this? You can get involved in maybe going to this project. It was really, it's been very interesting. For me, where people really pick up pieces of this. I mean, the political security, all these big topics, they can this whole section. You know, one thing is social media. Whenever the security comes out, social media is really a lot of it. I would have a big call of involved to help manage the marketing and media part of it. So we, yeah, so what is it going to look like? You know, that group of testing, the campaign process. County is very much but we need to empower.
And on our own, kind of similar topics, we're so passionate about it. This is another Yogo is graduated in the age and found our
This is such a great symposium. And I also love your, like, you know, how you started it. We're talking about children. And so we read the additions of have a little bit of energy to Alex. So we kind of like get into the as Ashley mentioned, Valeria Colorado is focused on the top of the program. Here's an outline of what we're going to talk about. So, as she mentioned, it's a childhood use of this education program for children, a culturally competent way of talking about culture and and it's kind of touching on some of the things we've heard about today. Language barrier, cultural competence, and as part of the children and their families. And also involving health professionals from the school, learning how to do this well and end up with so our specific objective for our program is to empower parents in specific clinics to improve their child's nutrition and level of physical activity. We do that by focusing on 3 different evidence-based methods. Learning the literature as well as some anecdotal information can have significant changes with significant impact on small pieces. That's one. Decreasing consumption of sugar and beverages, sodas, and already increasing awareness of the utilization of the mindfulness methods, so people can learn what they're doing, and also learn about what they're doing. And then 3, increasing the ability of families to know that their children respect studies. So a little bit about where we do this clinic. So Google Maps drive from Emory to Newport Highway. We would use it for all types of food in the world. Newport Highway is also an area of this circle back to the 25. An area of 10,000 food. We're excited about the people of the Georgia has a very fluctuating growing and so we work
population, it's not just concentrated, but it's always in the community. It's a nonprofit, it's called Drive. So this program came out about in fall 2012 during my pediatric outpatient rotation when I was working for the physicians that have about 1 in 4 of their patient visits in the follow-up group. Essentially what happens in the follow-up group is they define a patient is in the 85 to greater percent of patients are physical overweight or obesity, and they essentially try to do multiple visits with them to talk to them about how they eat, what they need to prevent diabetes, prevent obesity. But after the counseling, which is my view, only there wasn't really much that we could do someone else. As someone mentioned, strong life has this life model, but there really isn't much that is culturally competent or that is readily accessible for Latino communities. So based on that, I kind of created a health issue analysis. People don't have ambulatory, but this came out of my QI project for ambulatory. For addressing the QI project. And then based on that, it then led to doing windshield surveys, doing community assessments based on the indirect factors that are helping us. Created a logic model that had the goal of increasing physical activity teaching and identify these resources and then start to partner with them. Professional students, people like clinics, faculty, etc. Define their activities or outcomes and outcomes, and then engage with a whole bunch of other professional students to try to make this happen. I also, we also did, I took this model of this programming, so studying and true stuff as well, got involved in a Paul Andrews fellowship, which is something called Sculpture Vegetable Students, work on a sport program or something that they want to do with it. So from June to us and Paul onward, the project timeline, that we now have a program that addresses the goal that we have at the bottom here, having 3 workshops that in the fall, summer, spring, that address the things that we got grants from the school, help people do this.
So I was asking for my heads up. But so we work at the Brady Limber Clinic like David said, and we work with doctors Pimentel and Rodney. And they see 530 pediatric patients a month. 18% of those are for obesity checkups, and 85 of their patients are Spanish speakers. Really wants to be having more education clinics for younger patients and for their families in Spanish. So we have 5 one-hour weekly sessions at the clinic, and we hold these 5-week sessions 3 times a year. We're currently in our 3rd pilot. We target children ages 4 to 12, and also try to get their parents involved since it's really a family component to combating obesity. As I mentioned, all the classes are taught in Spanish. We cover 5 topics. The first is water and sugar-sweetened beverages. We try to emphasize increasing water consumption and decreasing sodas, juices, and other high-sugar beverages. We then in our specialty session talk about the MyPlate method and proportions. And we do so particularly to emphasize ways they can eat the foods they're currently eating in healthier ways. So a lot of our patients are Hispanic and Mexican specifically. So we try to incorporate portion sizes for the foods they like to eat and try to help them cook it in healthier ways. In our 3rd and 4th session, we talk about physical activity. So the PT students really help us to get involved in taking the kids outside and the parents also, moving physical activities. We talk about healthy snacking and grocery shopping. And then the 5th session, we talk about healthy cooking as a family, trying to get the whole family involved in cook healthier ways. We are currently doing pre and post surveys. This is solely for evaluation purposes, since we have an IRB waiver now to try to do our program. So what we do is we ask them questions before and after about their habits, and we try to see if they've changed over the 5-week period. Our curriculum is it started out as a 150-page English, written in English. It was created by Diogo and a group of Romans curriculum students. And since then, it has been translated into Spanish. Throughout the pilot year, we try to extend the lesson plans and add more clinical information and add more small group portions so that kids can stay engaged in the classes. The lesson plan is mainly objective driven. We give homework assignments to the family and kids throughout the week so they can stay engaged and try to implement the things they learn in class at home. We continue to retool the curriculum, and we hope that in the future we can extend this program to schools for kind of after-school daycare and possibly other organizations so that we can spread our impact along that way. So here's some pictures. This picture that I'm showing is just talking up here. Our first session is water and sugar-sweetened beverages. So we try to add 3 things to the water to convince the kids that it's just an enjoyable drinking and so and also a healthier option. And we give handouts throughout every session to try to keep them engaged. Our second session was My Plate Method and Portion Control, which is what we just finished recently in our third pilot session. Our third session and fourth session, we take the kids outside and we do some activities, whether it's hula hooping or Zumba type activities. And we also give kids snacks and teach them about grocery shopping. We try to emphasize grocery shopping in the Beaver Highway area because most of our patients live in that area. We try to tell them where they can shop and where they can buy healthy foods. And then session 5 is all about cooking as a family. We get the whole family involved and try to give them recipes and techniques that they can take back home. So the outcomes, we're still very young organization. We're just in our third session. We had our first in May, June last year in the fall. This is our second session. We've had over 25 health professional students involved. We try to take students from a wide variety of schools, the medical school, the nursing school, the public health, and also physical therapy students. In our impact, we've had over 35 children referred to our program. We've had 22 registered for at least one session. And then in our first 2 workshops, we had 9 families complete all 5 sessions. And we had a lot engaged in this current workshop, and we'll have that number soon. So in terms of outcomes, just simply on a pre and post survey, we have noticed a decrease in social consumption over the 5-week period, and also an increase in physical activity. As we get, it is a small sample size, so we're hoping as we add more and more workshops to our portfolio, we can hopefully try to find better data and also data to support our second goal, which was utilization and awareness.
A little bit about the challenges. So Anthony's going to talk about how we've taken our program or our logic model and implemented it. There are still a lot of challenges. This is only our first, we're coming up to the end of our whole pilot year. So our biggest challenge is we've established this organization that's we need money. We are funded through Medical Student Senate. Like I mentioned, we applied for some grants and received grants. We've also applied for grants and not received grants. So we continue to look for grant funding to help really keep the quality of the programming that we have in order to give people and families the resources to do something that they will then go buy after the session to do it. So we're looking for that. So that's the challenge we have. If you all have ideas, please let us know. We've got challenges out there so we can help us problem solve it. Second is Spanish translation. Both Anthony and I are highly proficient Spanish speakers, but we're not native speakers. So one of the things that we try to address this issue with Spanish translation is involving native speakers, but BMIS, we are looking for you wherever you are, in front of you. To also get feedback, we've also involved PhD individuals who have PhDs to help go through the language checks of our curriculum. Attendance is also a big issue. We'd love to reach more people, but right now the time frame that we have it is from 4 o'clock to 5:30, so your time. So moving into somewhere later would require us going to the facilities where we don't have to pay for our space. We currently have free rent for the clinic, so if we're to move it later, we want to find a place that we're going to host us for free. And then moving transportation there, because we used to give martyr cards in the first session, but we don't have enough to do that, so now we don't do that anymore. Space limitations are going to do that. And then resources. So we did talk a lot about how we give them information in their how to go grocery shopping. We'd love to give them more tips, more EET, help fair swipe things, or more physical activity places, or more vouchers from YMCA for them to do physical activities that expose them to a certain. And then, as Anthony mentioned, follow up. We do the 5-week pre and post testing, but what happens 3 months after?
So in the future, we hope to get a full IRB approval so that we don't just use our data for our program evaluation. We can kind of follow with the kids and families 3 to 6 months after our program and see if their habits have changed and if they're still implementing the good learning throughout our classes. We're going to continue applying for grants because money is a big issue. It currently costs around $1,260 for all 3 sessions throughout the year, so $420 or so per session. So we're constantly in need of more grants and more funding from the school and colleges and other schools on campus. We are trying to collaborate with elementary schools to try to make this more of an after-school daycare because 4 to 5 years is a critical time for families. We're hoping also for that elementary schools we can reach a wider audience. We're also hoping to create follow-up resources in the clinic and create educational space for the waiting room so that even if families cannot participate in our programs, they can kind of find some valuable resources that we teach while they're waiting in the clinic to see about treatment. So this is our current exec board, and we'll open up to any questions.
Shout out to Katie Hatfield, who's also presenting and helped in a lot in the first pilot. Thank you.
So I'm pushing forward. So we've got one more awesome talk. We'll lunch, so the pressure's on you guys. I'm super excited about this one too. It's near and dear to it's my future pediatrician heart. We have Ted Siegel, Kate Kulo, who are students here at Emory University. Being here today. And they are coordinators of Teddy Bear Hospital. It's a student-led initiative at Emory. It brings kindergarten classrooms. By the medical scholar. So we're super excited. I got running PowerPoint, sorry.
Okay, the work is between you and lunch, so let's take a 30-second stretch.
We have been doing that this week. I was gonna say the same thing. So definitely stretch it out if you want. It's also a little selfish and want you to ingest what we're saying as well. So good afternoon, officially now. Thanks so much for being here and for having us. Your presence is really meaningful. First, I want to say that it seems as if a pretty common theme this morning is translation. So how do we get the medical establishment down to people who benefit? And so where we fit into that is pretty early on near the faucet, if you will, the bathtub. And so we are translating the benefits of a healthcare encounter to children. And I think that's a pretty neat sort of theme and parallel that's happening throughout. So we're talking about Teddy Bear Hospital. So I'll give you a brief introduction of what that's all about. There we go. So the Teddy Bear Hospital is pretty simple. What we do is we go into, so far in our program, elementary schools, and we invite kindergartners to bring their teddy bears to school. My teddy bear is here, he's a big bear. He is also 23 years old, so he's a guy. And so they bring their bears. We briefly talk to them in the waiting room about how to be healthy, broad things they can do in their life, like wearing bike helmets, looking both ways before they cross the street, only letting their parents have the medication as opposed to taking on their own, that sort of thing. And then the sort of meat of the encounter is approaching a medical student with that bear and explaining to the medical student what's wrong with the bear. And the medical student, with all their tools and equipment and some even more advanced equipment, like you can see over here, this is our CT, X-ray, spiral CT, MRI. It can be whatever you want it to be. Really, that's imagination is a big component. And the medical student guides an encounter through which the child can explore what it is we do at the doctor, why we do it, and in a safe environment. So that's sort of the broad. And our impetus for doing this is the knowledge that medical anxiety exists, and this is what we try to address. I still have medical anxiety. Going into the doctor's office can be a scary thing at any age, especially as a child. And there are so many examples of what could be scary in the doctor's office, but one of which we focus is getting shot. So needles are scary. Like I said, there are people of all ages who are frightened of having an injection. And that's just one example of something, an object on which a child can fixate that is scary. It might prevent them from wanting to access healthcare, not only in childhood, but later on. We'll talk about that transition. So medical anxiety exists. Unfortunately, Teddy Bear Hospital is this tool that is used all over the world, which has been shown to be effective at reducing medical anxiety. We know this from the literature. And we're there's several ways that takes place. It's a complicated thing. We're going to emphasize in this presentation 3 ways that happen. So the first is we create a safe distance for these children. It's a second-person omniscient perspective. You remember your literature courses. So they are the teddy bear in so many ways. They project their imagination into it, but they can also step back and say, I'm not at the doctor's teddy bear. And that's really we try to make our encounters child-driven, but student-guided. And so they initiate the next step during the encounter. They say, well, we give them options, and they choose what we do. Is it time for a shot? Is it time to check their blood pressure? Is it heart pulse? Whatever. So they take this initiative, and the students guide and try to make sure that we hit objectives in this free-flowing thing. And finally, we try to give them a sense of control over their own health care so that they can stay healthy. We want to make them feel good about going to the doctor, but we also want to make them feel as if they're not at the mercy of the doctor. They have some and so I just want to sort of flesh those 3 points out, and we'll transition to Ben and healthcare disparities. So we create this safe distance. So sometimes a child will come up and say, my teddy bear has a tummy ache. And you think, well, they've probably had a tummy ache before, they don't like that, they feel sick, and they're sort of channeling that experience, and we go from there. Other times a child will come up and say, this teddy bear has muscular dystrophy. You think like, well, okay. You probably didn't learn that here in kindergarten. Somebody in your family has it, or you do, a friend, and in that, those two sort of approaches, those two backgrounds, are different in some ways and similar in others. And so they each give us the opportunity to let the child project into this teddy bear their fears, their concerns, and sort of we can leverage that to get them to process and think about what those experiences have been like, tummy aches and muscular dystrophy or anything. And it's child driven, so you're sitting there at a table, they have their bear, there's a bunch of tools, and you might pick one up and start there. So if you pick up a reflex hammer, you can say, well, we'll check the teddy bear's reflexes. And they're really imaginative young people to suspend and disbelieve in recurring ways. So you can hit the bear's knee, or have them hit the bear's knee, and then just push them there. I mean, it's really simple, right? But they're fascinated, and you can do the same for them if they're willing. Say, I can check your reflexes too if you want. Some of us are not all that great at doing that, but you can also let them listen to their heart. So it's child driven, but it's student guided. So we have objectives. We want to talk about vaccines. We want to talk about who can give a child medication and make sure they understand that they shouldn't just take it on their own, like it's candy or something like that. And we guide to all those objectives. And then finally, we give them a sense of control over their health. And this is actually the first thing they do. They come into the waiting room and people, medical students are showing simple diagrams. They're sitting on their level and just having a conversation about how you can be healthy. It instills a sense that they have control of that. And so all of this is designed to sort of inoculate them against being reticent to go to the doctor. And we think that there are some cool ways that that transitions into adulthood and it might start to break down disparities at the level of patient initiation of health care. I'll talk more about that.
So, yeah, so just to briefly reiterate what the research shows. So, we know that the Teddy Bear Hospital reduces anxiety about medical encounter. Specifically, research has shown that there's only been one empiric study or quantitative study looking at this and talking about hospitalization. So actually something that we're going to do in the future. This year, actually, we're going to do a study at a couple of different schools in the Atlanta area looking to see if the Teddy Bear Hospital method reduces anxiety, specifically related to shots and specifically related to going to an outpatient adult visit type of encounter. It also has been shown to improve medical knowledge. There was a study in Germany that looked at kids after they did the Teddy Bear Hospital knew where their organs were and were able to even draw them and tell you what they did. So this sort of this knowledge about their own bodies, and they were also more cognizant of what doctors play in their life. And the study that we did just last year, actually, we saw that the Teddy Bear Hospital is educationally valuable for students. We took a group of M1s, or first-year med students at Emory, and half of them got to Teddy Bear Hospital and half of them didn't. And we saw that the people who had the experience of doing Teddy Bear Hospital were more comfortable dealing with kids within a medical setting and had a greater appreciation for the role that medical play has in the So looking at some of what does this mean? So if we have less anxiety, then what does that do for us? And we would argue that it leads to better health. And just to sort of make clear, the Teddy Bear Hospital, we focus on Title I schools, schools that have a large portion of their students receiving free or reduced lunch. So these are poor kids, and what we found, or what literature shows, is that people who come from low-income areas tend to have sort of distrust of the medical community. If you've ever worked at Brady or at an institution like that, you can sort of see this sort of
hesitance to go to the doctor, and that starts very young. So there's the medical anxiety that we all have going to the doctor. Then there's medical this sort of distrust, this sort of disenfranchisement that's specific to this population. So when we reduce that medical anxiety, when we reduce their fear of getting shots, what happens? So the research shows that you get fewer missed appointments, so they're less anxious, so their parents are less anxious about bringing them to the doctor, so they go to more appointments. And going to more appointments results in better health. It also results in actually decreased pain sensation. So the actual act of receiving a vaccination or having a painful procedure done, if you're less anxious, and this is true for kids, it's true for adults, if you're less anxious about what's happening, you receive less pain. This feeds back into the idea that parental anxiety is a key feature in whether or not kids get vaccines and whether or not kids go to the doctor and how kids view the doctor. If a parent sees a kid being terrified every time they walk in the doctor's door, then they're not going to project positive ideas about the medical. So sort of speaking to this idea, this is sort of a neat thing to think about. So vaccinations is a big topic in the national conversation right now. The idea that under vaccination is sort of in the news, and we hear a lot about sort of the wealthy suburbs of LA and Florida and that kind of thing. People aren't giving their kids the measles vaccine and whatnot, but the reality is that lower incomes are actually associated with the fewest number of vaccines. This includes the infant vaccines that you get and also the yearly flu vaccine. So there's a need for sort of targeting lower income people to increase the vaccine. And what we would argue is that, again, this idea that the higher the perceived anxiety, and this is one of the major reasons that parents give for not giving their kids vaccines, so well, they're so terrified of it, it hurts so much, I don't want to do that to my child. And if the child has lower anxiety about getting the procedure, then the parents are going to be more likely to agree to give their kids the vaccine. Looking at it from a different angle, so if the kids are more aware of their bodies and more aware of the role that healthcare plays, and just in general more familiar with medical tools, we show them like our stethoscopes and our reflex hammers and our otoscopes and everything. The more familiar they are with that stuff, the better their health. And this essentially gets at the idea of health literacy. And health literacy is a huge issue in this population. And by combating that, there's a number of positive outcomes. For kids specifically, when kids are more knowledgeable about healthcare, more knowledgeable about their own bodies, they tend to have better control over their chronic conditions. So this is things like kids who have type 1 diabetes, or everybody who comes to the primary care clinic seems to have asthma of some sort. And one of the things you do in the teddy bear hospital is we have an asthma station where they get like a little, they can give their teddy bear albuterol treatment and have a little space with thing and oxygen mask and sort of empower them to sort of take control of their own health in that way. But also the kids who are more knowledgeable about their own bodies and about the dangers of smoking, which we talked about in our thing, are more likely to not smoke when they get older, and they're also more likely to be interested in health care. This is a big deal to us because if you look at sort of what makes up the healthcare workforce, there's about 10%, 9-10% of the healthcare workforce of the doctors and nurses are Black or Hispanic. And that's a large distance from how Blacks and Hispanics are represented. So there's disparities there, and the argument can be made that by having sort of a disproportionate representation of Blacks and Hispanics in the healthcare workforce, you get different sort of health outcomes for those groups. So we're not saying that by having a teddy bear hospital afternoon with us, they're going to go out to a doctor 20 years later. But we're saying that planting that seed sort of engages them in the conversation and makes them aware that healthcare as a career is an option, and that they can pursue that and sort of have. So where are we going to go from here? So this was a data light presentation, but what we're doing going forward, we have a research study we're doing this coming school year, where we're going to go into 2 schools and sort of try to quantitatively evaluate and qualitatively evaluate the effect that we're having in these kids' perceptions of going to the doctor. We also, I have mentioned the idea that having the parental perceptions of getting vaccines and having healthy behaviors affects how the kids behave. So engaging the parents is important. We have an idea of sending pamphlets to parents at the end of the encounter, with engaging the parents. And then the idea of continuity of care and health outreach. So you know, in my fantasy world, we would interact with kids at kindergarten, and then there was continuing interaction as they get older, so just continuing them over and over again with exposure to help their positive, friendly, fun environment. So we focus on 5 to 6 year olds, but other neighborhood hospitals in other states and other countries focus on, you know, 3rd graders and some even middle school age. Obviously, the language is a little bit different, but just sort of reiterating this theme as these kids grow up is really important. So with that, we'll take some questions.
One question for you, actually, so right now, is it only medical students involved in the program?
So, no, we have a couple PA students involved, mainly med students, and it's mainly just sort of access because of the people who've been coordinated within med students who are eager to get that. So we've had PA students get involved too. So we'd love to have, you know, we would love to reach out to nursing school and other schools. We'd love for, you know, we're only able to go to a couple of schools per semester, but it would be awesome if other schools, you know, Mercer and Morehouse and other places in Atlanta and Georgia could start their own neighborhood hospitals. If anybody can talk to us, we'll help you do it and sort of get the message out in other places.
So you say you come to a couple of schools, do you only go to schools one time a semester? Or do you go to schools again after you pay the fee? You don't have to go to that.
So that's a good question. So what we've done in the past is we go to one school per semester. We typically go back to the same schools year after year, but the model so far has been every individual kid will get one teddy bear experience, and it's just an acronym of the teddy bear hospital. Other programs have sort of do repeated visits. We just haven't adopted that model yet.
How are the key objectives of the visit determined? So discuss some vaccinations, for example.
Yeah, so how do we determine, so beforehand, we have a training day with the med students where we actually have somebody from Child Life show come in and talk to them about interacting with the kids and age appropriate language and that kind of thing. And we sort of we talk to them about the key things that we want the kids to get out of it. We want them to know, understand about the vaccine. That's sort of what we're really pushing. We want them to be aware about what happens, the process of what happens when they go to the doctor. That's the second one. And then in the waiting room, we talk about just general healthy behaviors. And so those are the 3 activities for the kids. And then for the med students, we really just want them to feel more comfortable talking to kids and more comfortable setting them up to get the vaccine.
Is anything else?
Yeah.
Super cute. I will be looking at all of them. Speaking of lunch, I know you're all so we have a lot of sandwiches back there. We got a lot of vegan things, chicken. We asked that you give priority to the salad for people that are gluten free because the sandwiches couldn't really accommodate that. But I'm sure there'll be extra. We also have some gluten free snacks and stuff that people need priority for people that need them. But please help yourself and then Chad and the wonderful postmates to see after. We might start a little bit later than you probably. So all right, thank you guys. Everybody. Sorry to hang on for getting in. I want to a little bit sort of the info posters, sort of adhere somewhat to the schedule for everyone, for all the speakers who are here. So we will jump into it. It's actually, as I said, we had a really, really cool talk scheduled, which might or might not happen depending on fate at the end of the afternoon. If it doesn't happen, I can email out the slides because I think it would be really, really interesting. But in the meantime, we have an equally awesome talk that's going to be presented by Ms. Maxine Warren. She's presenting her work with the Emory Refugee Alliance, or ERA, to support your medical students doing her master's in clinical research this year. She's been working with TISA Brooks today to talk about how they've been bringing Emory students into helping our refugee community. Here she is.
Everyone. My name is Maxine Warren, and as she said, I'm a fourth-year medical student. And I'm supposed to be presenting with the president of the ERA, but she had a canceled flight, so bear with me for the second half of the talk, which I will be presenting on her behalf. So thanks, Delta, for that. Okay, we're going to talk today about how students from all disciplines can learn about and get involved with helping Georgia's refugees. So first, a little bit about Clarkston. Georgia accepts between 2,500 and 3,000 new refugees each year. And in the 1990s, the government agencies were trying to figure out where to put them. So ideally, they wanted someone fairly close and accessible to Atlanta with a pretty cheap and open rental market. And they identified Clarkston and DeKalb County as fitting the bill. It's almost inside Metro Atlanta. You can see the little red star, and it's the last stop on a public transit line. So now, more than 2 decades later, Clarkston has become home to Georgia's largest population of refugees and displaced persons, with over 50% of the city hailing from outside the U.S. Sorry. Okay. Over 50% of the city hails from outside the U.S. And in just 1 square mile, there's representation from over 50 countries with more than 60 languages spoken. So currently, the most predominant nationalities are Bhutanese, Burmese, Congolese, Ethiopian, Eritrean, Iraqi, Iranian, Somali, and Sudanese. In fact, Clarkston is home to the largest population of Burmese people outside of Burma. Each ethnic group has its own community ties, its own language, its own religion and holidays. So although I'm going to talk about the Clarkston community as one entity, it's actually a diverse group of many different ethnic communities. So when a refugee comes to the United States, what happens? Well, in 1980, the Georgia Refugee Act authorized the creation of a refugee resettlement program, which is a federally funded agency that provides various services to new refugees, including English language instruction, employment services, health screening, social work, and medical and cash assistance. These services are coordinated with the private sector and a whole consortium of volunteer groups, religious and civic groups, which together provide more social support. The federally funded resettlement program, including the cash assistance and the medical assistance, is only available to refugees during the first 8 months in the U.S. So after 8 months, the assistance runs out and each refugee is expected to be self-sufficient. So basically, within this 8-month time frame, refugees have to find a home, find a job, find access to healthcare, and learn English. I don't know about y'all, but I'm still not fluent in Spanish after 6 years of formal instruction, so 8 months would not cut it for me. But as you can imagine, finding a home, a job, learning a new language, and trying to become financially independent in 8 months often take priority over learning to navigate a new healthcare system. With regard to finding a doctor, refugees get a quick workup upon first arriving here in the U.S., but that domestic health assessment focuses mainly on infectious disease exposure such as TB or parasites. These don't really address other important aspects of health such as mental health or management of chronic conditions. This is a problem because lack of quality health care in the refugee camp before coming here, combined with huge changes in diet once they are here, often precipitate chronic health concerns, including hypertension, diabetes, and weight gain. Not to mention extremely high levels of PTSD, depression, and anxiety brought on by the trauma of displacement, being forced to leave your home and members of your family and enter a whole new culture. Access to refugees is also complicated. Access to healthcare for refugees is also complicated by different expectations regarding health resources. Many of these people are not used to having a formal and complete healthcare system available to them, and often they underutilize resources such as family planning and pre- and postnatal care simply because they're unaware that such options exist. Different cultural beliefs also create barriers, including sometimes needing a same-sex provider or the stigma that often surrounds mental health in different cultures. Then again, there are basic barriers such as transportation and logistics, but essentially all of these issues combined make it easy to see why the refugee population ends up medically underserved. Emory students who are willing and able to assist with many of these barriers are in no short supply, and yet while Clarkston is less than 20 minutes away from the Emory University campus, Emory students and Clarkston residents have very little coordinated access to each other. Several factors contribute to this, and in particular the decentralization of both Emory and Clarkston. At Emory, every organization with an interest in international health or health policy has independently developed its own links to the Clarkston community without first researching whether there are any pre-existing relationships. This fractionation is compounded by the fact that there's little to no communication between the various graduate schools, graduate and professional schools. Similarly, in Clarkston, there are so many different ethnic populations that remain independent of one another due to culture and language barriers, which prohibits a cohesive interaction with the Emory community. In addition, there's many organizations already established in and around Clarkston to help refugees, including the International Rescue Committee, the Refugee Resettlement and Immigration Services of Atlanta, the Lutheran Services of Georgia, and World Relief, just to name a few. It can be hard to choose which to volunteer with. This lack of central organization and overall vision is what we interpret to be the limiting factor with regard to forming a lasting, impactful relationship between Emory students and Clarkston residents. In response, last year we created the Emory Refugee Alliance, or the ERA. We noticed the scope of Emory's impact in Clarkston has been limited in magnitude by the splintering of efforts between various student groups. So we formed the ERA in order to unify Emory graduate students from across disciplines, including the schools of public health, medicine, nursing, law, and hopefully business next year as well. Our goal is to create a pipeline to facilitate access between the two communities, creating awareness about the multitude of projects available, bridging Emory and Clarkston together. One of it we'll hear from after me. We hope that the relationships formed in the process will lead to mutual understanding, erasing of some of the stigma of the term refugee, and help to decrease the health disparities in Clarkston. To finish up just a little more about the ERA, this year we're working to collaborate with the Clarkston Community Center. We plan to improve coordination and communication between the two groups to best provide volunteers and service where it is most needed. This includes, but is not limited to, volunteering at health clinics and fairs, volunteering in schools such as the International Community School, which is an elementary school of mostly refugees, attending community fairs, and supporting resettlement organizations for new refugee arrivals in their orientation to Atlanta. Since the ERA is a student-led organization that represents all professional schools, we want to emphasize that our focus is not limited to health, but includes endeavors related to business and law and wherever else support is needed. At the same time, we plan to host frequent educational and awareness events to focus on current and neglected issues relating to refugee populations and global health. We're also working on getting an ERA website up and running that we anticipate will be a one-stop shop with regard to information about events, volunteer opportunities, and other things related to our area of focus. So stay tuned for that. And wonderful. Thank you.
Is your population of refugees mostly moved to the east, or what is the distribution of your population?
Mostly Bhutanese, but I mean, it's very diverse. So mostly Bhutanese is it's the largest population of Bhutanese people outside of Burma. So in that sense, there's a lot here, but it's definitely, I think, equally spread out. But there are translators available for all of the languages, so that helps. So the Clarkston, mostly through the Clarkston Community Center, which is a place where they go, and I think, Kate, are you going to talk about this? Okay. That's a place where they all learn to go for most needs. It's not just a clinic. In fact, the clinic they had just opened, but so mostly through our contacts in the area.
Do you know how they're getting connected?
Oh, mostly through the International Rescue Committee. So that is who helps their transition once they end up in the United States. So it sets them up with all these federally funded programs.
I apologize if I missed this, but in terms of, you're talking about how it's hard to coordinate between Emory different schools, and that's been a we've experienced both that, and a lot of us probably have experienced different capacities. So how do you exist as an organization? How do you kind of achieve, how can you all do this better?
That is a great question. It's definitely very difficult, especially in terms of advertising that you exist as a group. I would suggest having what we do is we have a representative on our executive board from each of the schools, and they're kind of the point person for that school and responsible for getting our name out. So we have a school of medicine representative, nursing representative, public health, no business yet, because I don't think they're that interested. Hopefully one day.
And are you a student group?
Yeah, a student group. And one good thing about it is that you can get funding from each of the schools, and then the school, Emory overall, the graduate school as a whole. So you have different revenue sources coming in, which helps.
You don't need to be a member.
That was really great, and we actually have something that ties in really well, as Maxine mentioned. So we have Katie here. She is going to talk to us about the Mommy and Me program. She's a second-year PhD student with Rollins, which is the public health school here at Emory. Over the past year, she's been working with the Mommy and Me family literacy program. This run in Clarkson, Georgia, which we heard about. For her master's thesis, she's developed a nutrition curriculum. For the Mommy and Me program, has been piloting lessons throughout the year. She's here to talk about her work experiences and talk about future steps we can look forward to. Katie, you want to come on up? Yeah,
All right, hi everyone. I'm Katie, and I am a second year at public health school, and I have been working for the past year with an organization called the Mommy and Me Family Literacy Program. Okay, so the Mommy and Me Family Literacy Program is an organization that is run through Friends of Refugees in Clarkson, Georgia, which we've already gotten the full background from Maxine, so I'm not even going to go into that. So what we do here is the mothers come in from all over the world. They're mostly Burmese descent, but there are other ethnicities, Ethiopian, Somalian, you name it. They come in and they're here to learn English. But it also serves as a daycare and kind of development center for the kids. So while the mothers are learning English, their kids are in their own classrooms with other kids of their age. They're all under 5. And the kids are learning English also, but also learning how to interact with other kids their age, and it prepares them for schools here in the US. So that's pretty much the structure of the Mommy and Me program. I started volunteering there last January, so January of 2014. And throughout my time there, I had noticed that some of these kids had come in, their mothers would pack them a snack, and the kids would come in with these snacks, and I noticed the nutritional quality is not very good. I would see a bunch of packaged foods, a lot of sugary foods, things that just didn't look so good. And another thing that I noticed is that the kids, who again are all under the age of 5, had a lot of dental problems, which stems from eating too much sugar at their age and drinking a lot of juice. So I was talking to the program director about this, and she said that she's been trying to get in a nutrition curriculum for a while. And so I told her, hey, I'm looking for something to do with my master's degree. So here I am teaching nutrition classes to them now. So that's the background of how I got involved with this program. And this quote here is just the kind of the mission statement that they follow. The best way for a refugee mother to learn English is in a way that supports her as a mother and promotes the literacy and development of her children. So kids and mothers learning together. So in order to tackle this program, I had to do a little bit of research. So I spent last summer going around Clarkston and researching what their food environment is like. And when I did 9 market surveys, I actually had a team, there were 3 of us. And so we went around, we did market surveys to find out what kind of food is available. And we did some in-depth interviews with a couple store owners, with some key informants from people from the Clarkston Community Center, and one very prominent community member. She's kind of like the Clarkston mother. And so basically what we got from this was just an idea of what is out there in the food environment. And what we found is that there were 2 big grocery stores that had a decent amount of produce. It's not a selection like you would find at a Kroger. The majority of the stores are all small market, small convenience stores that really just offer a lot of junk food. So that's one of the main problems. But the 2 full grocery stores, they did have an acceptable amount of produce, and so that was what we wanted to work with. So from that, I started the curriculum development process. So when I first started doing this, I thought, okay, we'll go with my plate. That's the standard for nutrition. And after talking with my advisor at Emory, we decided, no, that's way too complicated for a group of students who's there to learn English. So we went with the Go, Grow, Glow method, which is an already existing method that serves for low literacy groups and also for children. So Go, Grow, Glow means the Go foods are your carbs, Grow foods are your protein, Glow foods are your nutrients, so fruits and vegetables. And the idea is to teach this so that they know these are the 3 groups that I need to eat from. Anything outside of it is not necessary, but these 3 are what we need, and they should be in every meal. So that's what I decided to go with. I at first was going to do 4 themes to focus on, which was going to be dietary diversity. I was going to do infant feeding, access to food, and then I thought I'd throw in a physical activity component. But once I actually started piloting the lessons, I realized that I'm going to need to focus a lot more on emphasizing the Go, Grow, Glow theme. So I ended up just doing dietary diversity and access to food in 4 lessons in the fall semester and 4 lessons in the spring semester. To evaluate the program, I also wanted to do keep track of what the mothers were packing for their kids, because like I said, that's how I realized that there was a problem there. So I did a worksheet called What I Packed My Child for Lunch, which is right there. So they would come in once a week and they would write down what they packed their child for lunch that day. There were some problems with this as far as writing, since it is an English literacy class. That was one of the main barriers, and it's something that I am still working on. So to briefly run through what I did in the fall semester, these are the first 4 lessons. Lesson 1 is just introducing Go, Grow, Glow. Lesson 2 was kind of looking at Go, Grow, Glow in beverages, because the kids were drinking a lot of juice and soda. So to teach Go, Grow, Glow through that. The 3rd week we did snacking, and we actually made a smoothie in the class, and that was a big success. The 4th lesson, which I have not piloted, is a recipe makeover, which I wanted to just demonstrate that the foods that they were eating, such as instant noodles, can be made into a better meal than just the instant noodles. If you add fruits and veggies, if you add some protein, take away the seasoning packet. It's a really interesting lesson that I hope to pilot next year. So the first year what I piloted, and this is an example of the worksheet from the first lesson. So this was their homework, actually. They would go through and circle which, in different colors, which food is which. Spring semester was focusing on access to food, because this was one of the main problems, is figuring out how to access these Go, Grow, Glow foods in Clarkston. So the topics we worked on, the first lesson of the spring semester, I taught them what the word barrier means. And we went through what are the barriers to get food, to get healthy food in Clarkston. And so the first lesson was just talking about barriers. And we talked about the main one barrier of being, is it always safe to go by yourself to the grocery store? So the women all found a buddy, a shopping buddy, so that they could call them and go grocery shopping with them together. The sixth one, lesson 6, planning a budget. Lesson 7 is staying in charge of your child's diet, because a lot of times the mothers would just, if the child wanted a piece of candy, the mothers would give in. So figuring out how to stay in charge of your child's diet. And the last one is navigating the grocery store. So I piloted the first and last this past spring. And like I said, the lesson 6 was talking about grocery shopping buddies. So this was the worksheet that they got. They went around and they found 1 or 2 grocery shopping buddies. So the last piece of the curriculum is called Food of the Week. And this was actually just created about a month ago, when I was talking to the program director and I said that the quality of the snacks, of the kids' snacks or lunch at the school, is still not good. Sometimes some of the kids would come in, their mothers didn't pack them the snacks. So Mommy and Me program provides snacks for these kids. The quality of those snacks were not good. And so I asked her, do you need money for this? Because I had funding for this program that I've been doing. And I had some leftover funds, and I said, would you rather me focus the last part of these funds on improving these snacks? That's where the Food of the Week came. And it's about to start next week. So this is what it's going to be, is a separate piece of the curriculum, and this is what the worksheet looks like. So kids learn the food, and they color it, and on the other side of this sheet, this is a 2-sided sheet, they'll give this to their mothers, and this has what the food is, how to prepare it, where to get it, how much it costs, and a recipe. So the recipe at the bottom is what the kids have eaten and snacked that day. And one of the women who works at Mommy and Me is going to prepare the snacks. And I'm so excited about this to start next week. So check back in with me and I'll let you know how it goes. So, of course, there are some limitations with this. It was a large class size. There were about 30 to 50 women in each class. And they're all of different levels and speaking English. So there, of course, there were the women who would speak up a lot, and then there were some who wouldn't. It's only 30 minutes. With that big of a class size, it's really hard to do something successful in only 30 minutes. And like I said, the evaluation system needs a lot more work. But for improving and going on with this program, what I would really like to do is, of course, pilot the full thing, because this year has pretty much just been an experiment and actually writing the curriculum. So I want to pilot the full thing, which I have applied for funding, and I'm hoping to get funding to continue it on next year. And eventually, not next year, but eventually I would like to expand to a wider audience in Clarkston, because like Maxine was saying, there's a lot of disconnect in Clarkston. And I think nutrition is one of those things that should be taught throughout all of Clarkston when the refugees come in, when they're learning English. That's the main thing of this curriculum, is teaching nutrition in an ESL classroom. The other main component of the curriculum is teaching it in an empowering way, because they're a vulnerable population. The last thing that you want to do is go in there and say, don't eat this, because that's not gonna work. So continuing it on, smaller class sizes, longer amount of time, and continuing to be culturally relevant and teaching an empowering way. Thank you.
actually do when you have them, identify groups and kind of where things fall into, like, see if they kind of get better with their teaching or just kind of wondering.
Yeah, so that portion of the curriculum is actually to the mothers. And the mothers, they caught on, and they all know me as the Go Grow Glow person. So, yeah.
You had the discussion about barriers. Were you surprised by any of the barriers that were discussed by the moms?
No. Actually, they said exactly what I had planned for them to say, which was, which was telling their kids wanting certain foods and them giving into it, money. I kind of planted the idea of them that maybe going to the grocery store alone isn't a good idea, and I got that from my research I did over the summer. They went along with it. They seemed, I think that it was helpful for them because the next week they did say that they went out and they went with a buddy, so, yeah.
What's the rationale behind the buddy system? What are you hoping for them to accomplish by doing it together?
Like I was saying before, when I did the research over the summer, through some of the in-depth interviews with key informants in the community, I had found out that there are times when it's not safe for women to go to the grocery store by themselves, especially if it's at night. So, yeah.
Okay, thank you.
Yeah. Thank you.
No, those were really great. I feel like we're very fortunate to have such a rich cultural area here, very close to us, and I feel like we take advantage of learning from them as Georgians kind of helping this population. I think lots of that's really spectacular. So Vinny's ready. So Vinny is our next presenter. Barbara, he's a fourth year medical student at Emory School of Medicine. He's been in the same field from started working at Grady Homework, probably all know Grady pretty well. And he's the first one. It's really important topic.
Hey everyone, so my name is Vinny LaBarbera, and as actually mentioned, I'm a medical student at Emory. And my project's entitled Giving Shelter, Review of Homelessness Statistics and Associated Biopsychosocial Issues, with an emphasis here in the state of Georgia. And I sort of got the idea for this talk because I wanted to educate myself. Rotating through Grady, it's a large indigent population. And I was sort of surprised by the magnitude of the homelessness issue here in the city of Atlanta. And I just wanted to have a chance to educate myself and a chance to show some of the current statistics that I came across with you all today. So learning objectives, I want you all to walk away with a definition of homelessness as it is described in the literature. I'll display some homelessness statistics as they pertain to Georgia, and I want to discuss the biopsychosocial implications and complications of healthcare for homeless populations. And of course, there's my underlying objective that it's a huge problem in the state, in this country, and something that I think would be helpful for all the folks in public health as well as those on the clinical front lines of that. So methods for this data acquisition, where I did a review of the annual homeless assessment report to Congress, here for reference to as AHAR, and the Georgia Department of Community Affairs DCA report. I reviewed those and pulled out current statistics as they apply to Georgia. This information is generally available to the public. If you just Google AHAR homelessness or Georgia DCA report, you can also find these numbers. And the second part is I actually did a PubMed search using criteria of homelessness, health, homelessness, stigma of homelessness, and homeless Atlanta, Georgia, with several articles I selected as representative for today's talk. So homelessness as defined by the AHAR is defined in several ways, but I pulled some of the more pertinent definitions here. So chronically homeless individuals are unaccompanied homeless individuals with disabilities who have been either continuously homeless for over a year or have at least 4 episodes of homelessness in the last 3 years. So that's the definition of chronically homeless. This definition of chronically homeless can also be applied to families where the head of family is disabled and fits some of these same criteria. So then after this, we have unsheltered and sheltered. Unsheltered, as you can imagine, there are people who stay in places not meant for human habitation. So those are such as the streets, abandoned buildings, parks, etc. Sheltered homeless people are individuals who are staying in some sort of housing program. So that's either emergency shelter, transitional housing program, or safe havens. Safe havens are either permanent or semi-permanent housing for folks with mental illnesses. However, there are some certain limitations to these safe havens. Only 25 people can be allowed in one domicile at one time. So on a single night in January, so I'd like to say we'd all be sitting here in the Georgia Dome in January watching us play the Super Bowl. That probably won't happen. But just keep in mind that a single night in January, if you are here at the Georgia Dome, you're sitting with approximately 71,250. On a single night in January, there are 578,224 people who are homeless in the United States. So that sentence on a single night in January seen over and over again in the AHR report. It is one of their data acquisition points, where all the continuums of care and the different organizations in the country made a census of their homeless populations, and I believe Health Stat took part in that for Atlanta. But just imagine 578,000 people. That's enough to fill 8 Georgia domes. So the magnitude of that problem in this country is just, it's mind-boggling. It's crazy how many people are there out in the world just being homeless. So again, this exhibit 1.1, the first image from the AHR report, shows the data of the census of homeless people in the United States from 2000 on. I got the most recent data available to me. So as you can see, there is a slight decline in the total, going from 650,000 in 2007 to 578,000 in 2014. So we are making progress. The country is making progress in bringing down the number of homeless people. However, like we mentioned before, that number is still just at an unacceptable level. So this graph also breaks it down to sheltered and unsheltered, with the majority of homeless people being sheltered in some sort of domicile, but still the problem of unsheltered homeless people is still at 177,000. It's quite a lot. So again, the HR report, which I suggest you all take a look at, is really nice. It broke it down state by state level, which is very interesting. So here in the state of Georgia, we have 16,521 homeless people on that single night in January. So it's the second most in the southeast region, followed second to Florida at 41,000. And of those 16,000 people, 12,000 and change are homeless individuals, and 4,000 and change are homeless people and families. So although the homelessness issue in the state of Georgia doesn't quite compare to the numbers in California, for example, or New York, is still quite a large number that I think we can all do something to help develop. So Georgia, unfortunately, is in the top 5 of this statistic, something that we don't want to be in the top 5 of. Approximately 50% of our homeless people are actually unsheltered. Just imagine, we had a couple of really cold snaps here throughout Atlanta, and I was going through my emergency psychiatry rotation at the time. And there are just a few very heart-wrenching stories of these people with mental illnesses who unfortunately passed away because they were on the street and didn't have the wherewithal or the capacity to find a place to stay. Just keep that in mind. So this next slide is the unaccompanied homeless children and youth. Children defined as under the age of 18, youth under the age of 24. And again, here in the state of Georgia, we have 1,000 children and youth homeless. Next is the estimate of homeless veterans. So this is defined as the proportion of homeless adults that are veterans. You can see in the United States, approximately 50,000 homeless veterans. That makes about 11% rate of the homeless adults who are veterans. Here in the state of Georgia, we have approximately 1,400. So in doing the simple math, our homelessness population of adults who are veterans is about 9.3%. While it falls slightly below the national average of 11%, you still see the magnitude of that problem. And the Department of Community Affairs in Georgia actually does an interesting thing. It breaks it down, the homelessness population breakdown by county. So as you can imagine, the majority of the homeless population lives in and around Metro Atlanta, with Fulton, Gwinnett, and DeKalb County in the top 4. What sort of was interesting is that Chatham County on the east, sort of its own little island of homelessness. It's the second most in the state of Georgia. So homelessness as a medical problem, I know we all have an instinct that is a social problem, but does it really affect a person's health? And the medical students in the bunch, we all know we take a social history, but oftentimes when you're visiting the clinic, that's often just, do you smoke cigarettes, do you drink alcohol, do you do any drugs? And sometimes the housing situation sort of goes by the wayside. But I'd like to argue that in your past medical history, homelessness should be a question you need to ask. So I'll talk about the biopsychosocial model, which is a clinical philosophy of interacting with the patient. And it actually it takes these three realms of biology: the person's genetics, person's gender, person's medications, what they're doing to affect their physiology, their psychology, so their memories, their experiences, their personality, behaviors, and finally their social context, social supports, education, etc. And I thought that homelessness is a fantastic model to fit this biopsychosocial model. When a person who's experiencing homelessness comes into the clinic, it's important to take all these into effect to direct their management of their medical problem. From this really interesting review by Fazal et al. In The Lancet showed that there is indeed a mortality and morbidity associated with homelessness. There's excess mortality when compared to the general populations through things like infectious disease, HIV, tuberculosis, or high among them, cardiovascular disease, abbreviated as CVD, and external factors like accidental and non-accidental trauma or climate, make homelessness an independent risk factor when taking into account for age, gender, etc. It's an independent risk factor for mortality. So it also affects morbidity. There's an increasing age of homeless folks in this country, with a median age of nearly 50 years old. Increased risk of mental health and substance use disorders. The infectious rate is increased with things like tuberculosis, HIV, and all the different hepatitis viruses. Again, cardiovascular disease and modifiable risk factors, including smoking and healthcare use discrepancy. And that phrase, healthcare use discrepancy, describing the preferential use of homeless people to use the emergency department of the hospital as opposed to establishing care with a primary care physician. So this interesting cross-sectional survey by Wiersma, actually here in Atlanta, demonstrated this issue. So their survey of 123 people, the median age was 46, mostly male, mostly African American. A majority had a shelter stay in the past 70 days, and 15%, a non-small minority, had a street stay in the past 50 days. 42% had a chronic medical illness, and nearly 25% had an influenza-like illness in the past 30 days to go for the more acute, if anyone's experienced acute illness. However, only 30% received the influenza vaccine. And of 79 of those folks who describe receiving medical care regularly, 63% say they use the emergency room or the hospital for their primary care. So we talked about the biological, biomedical morbidity of homelessness. What about the psychosocial morbidity of homelessness? In the study by Zerger et al. Up in Toronto, they saw that stigma, whether perceived or real, actually is a major psychological stressor to these people. 73% of their cohort described some sort of discrimination. So these homeless folks with mental illness, they described some sort of discrimination. As you can see here, the major ones are discrimination due to their homelessness or their poverty. 61% saying they describe some discrimination. Ethnicity or race or skin color, and mental illness or other their alcohol or drug use. So this population is very vulnerable to receiving this discrimination. So the same research group, this paper by Sariba et al., took a similar group and asked if they received discrimination in the healthcare setting. So of this 550 group, where 90% of these people say they received some sort of outpatient care, 42% of the respondents described at least one episode of discrimination in the healthcare setting. And 58% of them had at least one visit to the emergency room in the past 6 months. So this sort of brings about two of the points I'm talking about. The majority of homeless people use the emergency room for their primary care. And discrimination isn't just in the streets, it's actually in the clinics. So future direction, how can we quell this problem of homelessness? So there is targeted funding. The Department of Housing and Urban Development has had homeless assistance grants funded at $2.1 billion in the year 2014. How that money is distributed, I actually don't know. But questions for you in the audience, some things to think about regarding the issue of homelessness in our community. Should there be more emphasis on affordable housing, or should the more emphasis be placed on getting these people to primary care or mental health service resources? What can we each do in our own immediate vicinity? So I'll end with this quote by Mother Teresa. Sometimes we think that poverty is only being hungry, naked, and homeless. But the poverty of being unwanted, unloved, and uncared for is the greatest poverty.
And great talk. And I know you focused on like U.S. and Georgia, but like I've met people like anecdotally like traveling from other countries, Europe, Latin America, and they're describing their experience in the U.S. seeing way more homeless people than they've seen in the how does the U.S. compare? Knowing the stats on that, how the U.S. compares with other developed nations around the world in terms of like, why is it? Yeah, you talk about. I mean, all the time, why is it coming to America? Don't worry, I can have
Yes, that's an excellent question. I actually don't know for the purpose of this talk. I want to use just Georgia for health stat purposes, but that's an excellent question. Anecdotally, one thing that I've talked about with my attendees is the plural of anecdotes and data, so keep that in mind. But anecdotally, there's homelessness everywhere, I think. But I've also heard the same thing where it seems like the problem of homelessness in this country is more out in the open as opposed to some other countries. But I cannot give you any statistics.
I certainly don't know any broad statistics on it, but I do know that Marshall Harris at Home attended a street medicine symposium that happened in Dublin, Ireland last year. And the homeless count in Dublin, Ireland was 449 people, which is a very low number and an incredibly specific number. So just one number.
This is more of like a domestic and like a number because people within the U.S. I think there's a kind of a thing where in places where they're very good at addressing homelessness or the community and folks trying to address that are very well organized, they might count better. We did some listed on here for the homeless count when I went to Seattle. That was actually really, it was raining the night we did it, and some of our leaders didn't show up, and we did not, I was downtown Atlanta for a town, and we did not cover a good portion around here. We have police officer with us who have kind of stayed with us and yelled at us and went far away. This doesn't seem very ideal to find homeless people who are obviously like intimidated by the police quite often, otherwise when they're sleeping outside, because they people. So I think that it's also striking that the group numbers don't net numbers. So they are probably higher, like street numbers are probably higher than they are. At least my limited experience also points to that.
Do you have any recommendations for how people as providers can ensure that they don't inadvertently give off a sense of like looking down on homeless people?
So something I like to do is I ask it of everyone. I ask what your housing situation is, and if I sense resistance or anything like that, I will always make the disclaimer. Oh, I ask these questions of everyone. When it comes down more to the checklist type of questions, I say I ask this of everyone, and that in my experience that has eased some of the tension. But I will always ask. I'll always say, some of these questions might be a little bit sensitive, but I'll let you know I ask this for everyone. Do you smoke cigarettes? Oh, how many cigarettes do you smoke? Alcohol beverages do you drink? Who lives at home with you? And then that usually opens it up to a situation of, oh, I'm living in a shelter right now, and that brings us down that alleyway. So yeah, but I think making it standardized, making the way you ask it standardized, and definitely not giving off a sense of, like you're saying, just not giving off a sense of looking down on someone for their housing situation, their circumstance that you're living right now.
Certainly don't want to use another one for that. Another great way
would be to get involved and to work with providers who work with this population. So for those of you who are interested, you are welcome to come to our next keynote meeting, July 11th. You're going to be doing this today.
I'll be set to go on the treatment CT next month.
Quick question on the numbers again. Why did they choose a night in January? I obviously know that's winter for the northern states, and kind of makes it easier to count. But I would imagine down south, the heat becomes upon the summer. So I guess, do you know why they chose January?
Yeah, actually, I don't think they didn't explain that in the review, but for all the years past, they always just use the night in January. Maybe you guys have done the
I have some vague memory that it might be like the coldest night in the year kind of thing, and that's something people are sympathetic to. I mean, I don't know, I guess historically it's been like that, so I don't know how much of it is, like, that's when there's the most risk, like overnight, it's not probably not when it's heat, the biggest risk of people, you know, so I guess it might be like, I think most people die of hypothermia. But, and I think so might be also, I don't know how much it's actual versus.
there's likely a component of logistics into, that's when they can get the most volunteers in January. It's right in the middle of the school year for the college folks, maybe. I don't know, that's a great one to speculate on, but it wasn't specifically stated.
Thank you. I think it was really great. It's an important topic. No matter what you're interested in, adults, kids, next we have Julia, who I know pretty well. She is also a rising fourth year medical student here. Her interests are actually in women's health, which this is a big problem in that. She's ran a free women's clinic here in Georgia that recently started HIV testing. So she's going to talk about sort of trends with them and Georgia's role.
So I'm here to talk about this. Can you all hear me? So I'm here to talk about HIV in Georgia, in particular as it pertains to the women's clinic population I work with. So the objectives of this talk are to provide background on HIV/AIDS, on the HIV/AIDS epidemic in Georgia, to describe factors associated with negative outcomes, and to detail one local effort to improve HIV testing, diagnosis, and follow-up, as well as to elaborate on other resources in Atlanta for high-risk population. So my methods are kind of similar to Vinny's. I use the Georgia Department of Public Health statistics as well as the CDC website to gather most of my data. All this information is updated annually, but you'll notice that most of it's a few years back just because they collect the data for a year and then process it for a year and then publish it in September of every year. So most of the statistics will be from 2012 to 2013. I also did a PubMed search to kind of gain some evidence-based context for some of the phenomena that I will be discussing. And I also used patient data from the local clinic surveys. So as some background, at the beginning of 2012, Georgia had the 6th greatest number of people living with HIV in the United States. As you can see, the darker red colors means a higher prevalence of HIV. And the prevalence of HIV in Georgia is 508 per 100,000 people, which is 1.8 times the national prevalence of 285. And you can see the clinic primarily serves an African American population. You can see the breakdown of Blacks versus the general HIV population on this table here. So in Georgia, they account for 64% of adults living with HIV, whereas it's 44% nationwide. They also account for almost 80% of deaths associated with HIV infection. And this isn't getting much better in Georgia, as the case rate of new diagnoses of HIV is 10 times higher in African Americans than it is in the white population, with it being 53 per 100,000 in African Americans
versus 5.6 per 100,000. So 63% of people in Georgia living with HIV or AIDS live in the Atlanta metropolitan area. So this graph on the left, I believe, is incidence, and the one on the right is prevalence. Okay, so left is prevalence, so right is incidence. And you can see that, again, darker colors means higher number. On the left, it's showing that it's existing in a certain pattern, and that pattern is kind of being perpetuated. Within this epidemic, the Atlanta metropolitan area meets the criteria for a localized epidemic with 1.1% to 5% of the population meeting the disease criteria. So within this epidemic, African American women are disproportionately represented. They account for 75% of women with HIV in Georgia, and this is 13% greater than the national average of 62%. And despite comprising 75% of females with HIV, there are only 32% of the population. So this is a very disproportionate representation. So in the PubMed search of looking for factors that can contribute to this, a lot of the literature supports socioeconomic factors influencing high-risk sexual behaviors. In addition to that, food insecurity, homelessness, and low future prospects were associated with 2 to 4 times increased likelihood of engaging in high-risk sexual behaviors. And anecdotally, this week I was sitting next to someone doing a study on dual protection at Grady. Dual protection is using like a long-active contraceptive device or some sort of like birth control in the form of a pill, in addition to a condom to prevent sexually transmitted infections. And they were wondering why certain populations weren't using dual protection. And they said that they had focus groups, and the focus group found that a lot of young African American women used the concept of trust to not use the condom. So they're saying, I trust my partner, therefore I do not need one. Whereas in other cultural contexts, that might not be the case, and that could be contributing to this as well. And one study based in Atlanta demonstrated that food insecurity was independently related to HIV viral suppression, which I thought was very interesting. And those with unsuppressed HIV were more than twice as likely to have unstable housing and unreliable transportation to healthcare, which ties into some of the homelessness aspects. So we have this population, and there are numerous clinics around Atlanta serving it, but one of them is the Harry Tubman Women's Clinic, which was founded by Emory medical students in 2010. The goal was to provide free reproductive health services to homeless women in Atlanta. In 2012, they served 166 patients over 30 clinic nights and had more than 60 medical students and physician volunteers. The patients are predominantly African American women, ages range less than 18 to greater than 55. And that's very interesting because the greater than 55 age bracket is actually the third most quickly growing age bracket diagnosed with HIV in Georgia, third behind African American men less than 18 and African American men between 18 and 35. 54% of the clinic's patients in the year 2014 had not been tested for HIV within the last year. 22 had never been tested, and more than 13 requested HIV testing, even though we did not offer it. And then that pie chart on the right, you can see the composite patient income of 83% taking tested blood costs a year. So to meet this need, the Harry Tubman Women's Clinic partnered with Sister Love, which is an organization that was founded by women interested in education and AIDS prevention. Their mission was to eradicate the adverse impacts of HIV and AIDS and other reproductive health challenges upon women and their families through education, prevention, support, and human rights advocacy. So now they come to the clinic every Tuesday night. An average of 6 patients will be tested through Sister Love at each clinic. The patients who come in for other reasons often elect to undergo testing anyway. In addition to Sister Love, we also had a grant that has supplied quick swabs, so if Sister Love ever isn't there, we can still test for HIV. So there are some other local resources too. The Ryan White program is very well known. It's actually a national resource. It allocates federal funds to states, cities, and healthcare organizations to help supplement finances for primary care for people affected by HIV/AIDS and help defray other costs. There's also the Ponce de Leon Center in Atlanta. It's the largest and most comprehensive HIV care center, one of the largest and most comprehensive in the country. It sees over 5,000 patients, and 70% of the patient population affected by HIV/AIDS in Atlanta lives within 2 miles of the clinic, so it's relatively accessible to them. And lastly is AIDS Atlanta. It's one of the oldest comprehensive HIV/AIDS care centers in the southeastern United States, and it was founded in 1982 in response to the impact that the HIV/AIDS epidemic was having in the 70s and 80s. So they tested more than 2,000 people on their site last year with a 3.3% positivity rate. So in conclusion, the HIV/AIDS epidemic is of significant public health importance in Georgia. African American women are disproportionately a high-risk population within this cohort, and the Harrington Women's Clinic, which serves this population, has collaborated with Sister Love to decrease disparities in access to testing and care. And then acknowledgments to the clinic and its patients and volunteers, to Sister Love for coming and testing and helping our patients to care when they do test positive. The United Health Foundation and United Medical Fellowship for supplementing our testing with the OraQuick swabs into the opioid community pharmacy clinic. More questions? So it was a very, very complicated path. So yes, there's a lot of pushback because there's a lot that comes with having testing of a federally reportable disease to a very small, under the radar clinic. So yeah, there's a lot of hierarchical pushback because there's the moral aspects. Of course, there's like the legal aspects, and then the moral aspects are you have to like these people up. You can't just strand them with this diagnosis. That changes their entire life. So yeah, it was part of it. Thankfully, Sister Love is amazing, and they connect the patients to care, and they do pre and post test counseling. So they alleviated so much of the burden off of us, and then enabled this to happen in a quality way that it otherwise would likely wouldn't have been able to happen, or would take a lot longer to make happen. Thank you.
Our last talk kind of sums everything up really, really well. I'm really excited for this one. It is by every medical students rising 4 years. Between them have a lot of experience in teaching. Really impressive things. They teach for America, work with a curriculum in med school, have done casework, pretty much CDC, anything you can think of, they've done at a very young age, collectively within a lifetime's worth of age. So their passion lies in teaching these things that some of us maybe already have an idea of, but how can we kind of deliver this to medical schools and other curriculums, social medicine, health and justices. So we have 3 people here. We got Erin, Natalie, and Larry.
This is working, okay. So we're going to talk about what this means from us, our perspective from a medical school curriculum. And I'm going to start us out. I'm Natalie. So I know a lot of you have probably heard, I know I have in medical school, a health disparity offered very quickly, often in this number per 100,000, and African Americans are disproportionately affected, and then they move on and they don't explain it and have no idea what the context means or how many people is that really? And in public health, they're a little better sometimes putting these numbers into terms you understand. And one of my favorite papers, I don't know if there's Morehouse people here, David Satcher, wrote a paper looking at the Black-white mortality gap and showing that it actually, like age by age, hasn't really decreased between 1960 and 2000. That you'd think those disparities would have gotten better, but for the most part, other than for African American women in certain age groups, it hasn't. And over 83,000 excess deaths this year would have been prevented in the US if that mortality gap were eliminated. That's like 167, 37, 37. So think about how many people that is, and that's what we allow that to happen every year. And I'm on my 7th trip at Grady right now, and I often look at the patient list and think of how young the people on my list are. They're like often, most of them are younger than my parents, who are still very healthy. And this is, you can see disparities based on education and race. And if you look at how many people are 65 or less than 70 who have not graduated from high school, that's the average life expectancy. So white men with less than high school diploma have basically lived 13 years less than those who have had a graduate level of education. And if you think of how many years in addition to those like life expectancy years are quality of life differences years, it's pretty extraordinary. So where do these disparities come from? We can imagine that like the same determinants of health, same things that determine health are what determine these disparities. And most of that is social and societal characteristics. Things like poverty and racism and housing and fundamental parts of our society. When we express interest in these issues, though, a lot of times as a medical student, people are, well, if you care so much, why aren't you and then insert thing here. Like when I'm in public health, they're like, why aren't you in public health? Why are you a social worker? And I think, from the medical care, when I was at CDC and people say that about health behaviors, like, well, that's true, but people make those behavioral choices in a context. Like where they live, where they go is often, what their social environment looks like is often determined by those same things like poverty and racism. And as in medical care, it's such a small percentage, relative to everything else, but those social factors affect whether someone can have an appointment or get to clinic and what the power dynamic is with their provider and can they get the medicine they need. So it's important for us in our little zone, but also we have to think of, should we really be ignoring the larger zone when those things are such a huge determinant. So Paul Farmer said, does our clinical practice acknowledge what we already know, namely that social and environmental forces will limit the effectiveness of our treatments? Asking these questions needs to be the beginning of a conversation within medicine and public health and not the end of one. And that's something that we've really been trying to talk about is, we shouldn't just be thinking about, like the way Vinny was talking about for social history. It shouldn't be always the last kind of tiny thing. We need to train people to at least think about it as clinicians, first and foremost, because it's such a huge factor, even for individual patients with the larger system. So how have we been doing this so well so far? A lot of times we learn cultural competence, and that's kind of there's been the start in terms of educational, but cultural competence isn't that great. So like a woman says cultural competence, she's ready to go to Grady, but she's really privileged, comes from whatever background, but cultural competence often conflates culture with race, ethnicity, nationality, language. It says like, you're just thinking about culture, there's nothing else going on here. It reduces culture to a trait list. I don't know how many of you have ever taught Asians are like this. African Americans always believe this, and that's always often not true. Culture is assumed to be homogenous and static. It focuses on the client beliefs or the patient beliefs and not your own. We think, oh, we don't have a culture, but that's just because we're part of the majority culture, and biomedicine has a culture too. And just because we're not part of it, so we're not aware of it, doesn't mean it's any less something that has to be explored. And it also is like it's something you can graduate from. So then there's this idea of cultural humility, which is kind of the next step. And it's about training someone to think about their own culture and biases, making it a lifelong process, making the patient the expert, be willing to say, I don't know, and that's a step in the right direction. But it doesn't also take into effect all those other structural factors that we've been talking about for the most part here. And there's this amazing article that talks about structural competency, which the authors describe as the trained ability to discern how a host of issues defined clinically as symptoms, attitudes, or diseases, a whole bunch of things, also represent the downstream implications of a number of upstream decisions about such matters as healthcare and food delivery systems, zoning laws, urban and rural infrastructures, very definitions of illness and health. I think that word decisions is important. These things don't just exist in a vacuum. There's policies or lack of policies that let these things exist. They're things that are part of our society that we can affect change on. And another point I really appreciate in the article is when structural violence, systemic institutional stigmatization, and marginalization is an issue. We train doctors to look at individual stories, not just structural ones. So something that we wanted to start working on is how can we improve this idea of structural competency in our curriculum? You know, so people can recognize in the clinic what are those structural things going on that can affect their patients. Have a language to talk about the things going on outside of clinic. You know, not just think about culture. Imagine what you could do to affect change, to affect structural change, and have humility about structural forces in the same way we would want to have about cultural things. Which is to say, try to understand, realize people never understand, try anyway. Most of us come from privilege, and it's really hard for us to understand those barriers our patients are facing. So why teach it? You know, we're going to go to grade, we're going to get trained, we're going to see it, and I think sometimes there's this notion of if you're going to be a clinician, you're exposed to it, you're going to understand it. But like I said, we're a pretty privileged group. This is the quintile income in the U.S., and this is how we are in medical school. And so if you look at private medical schools like Emory, so, you know, about 80% of people are in the top 2 quintiles, so in the top, like, 40%, you know, over half of us are in the top 20%. And very, very few people come from the lower, like, 2 quintiles of income. We're not very diverse. We're about, whites are fairly equally represented in medical school population, Asians are overrepresented to some extent, and everyone else is underrepresented. And we grew up in segregated neighborhoods, and that comes both in terms of race. This is one of those maps, I don't know if you've seen them, where they're great to look at, where you can see the distribution. So this is Boston, actually, and the blue is the very concentrated population, African American population of Boston. And in terms of, so we're very segregated for the most part, in terms of, if you look at numbers, in Atlanta, something like 80 to 70% of African Americans have to move to be not segregated, and it's not the most segregated city. And also in terms of income. We're increasingly living more, for low-income people living more in low-income areas and higher-income people living more in high-income areas. So this is our perspective. So when we started out, we also wanted to hear the perspective of other Emory students to figure out, are we, like, does anyone agree with this? Like, we need to do.
Okay, so to do that, I'm Erin, by the way. To do that, we actually sent out a survey. So we did an electronic survey that we sent out to all the medical students at Emory. So we included a list of questions. We also gave some areas for people to give their comments. And this was probably one of the more striking statistics that came out of the survey. So we had one question asking how, what is your interest in social medicine in terms of all the factors outside the clinic area that affect health? And so what we found is that the large majority of students across all M1 through M4, they had a decent feeling about the importance of understanding these concepts. You see it from like 4.3 to 4.7, it's like using a Likert scale. But then when we ask about the familiarity, so if you feel comfortable addressing these issues as a clinician when you're working with patients, we found that while there is such interest and there's such view of this being important, that the actual students feeling comfortable, that was actually lower. So you see ranges from 2.6 up to 3.3. So this is even M3s and M4s who have gone through grading, received this sort of education within grading of understanding all these concepts supposedly, they still graduate from Emory not feeling comfortable addressing these issues as a clinician. And so we also kind of broke this up, seeing trends in preclinical, so medical students who haven't actually started their rotation in grading, and then also talking to students that had actually started and kind of experienced all the rotations. We found that with preclinical students, they had a lot of experience before medical school that seemed to kind of prep them for this sort of instruction, whether it was doing Peace Corps or doing some other volunteer work, where they really were working with these sort of factors that are affecting health. And we found that these students often wanted to have these factors included in the instruction, whether that's with patient interviews, when patients are coming into the class, or in our small group sessions when we're actually going through cases and not just focusing on biology, but also talking about a lot of the social issues that are also going to affect patient care. With the older students, something we really wanted to look at is this idea of grading being this sort of teaching ground of social medicine. Leaving grading, knowing everything that is to know about social medicine. And so when we talk with students, both in the survey and also in our focus groups, we found that while there is exposure, that exposure does not necessarily mean that people are equipped. So you see things, but if you haven't received any context and you're also not explicitly trained, that doesn't guarantee that you can actually handle or understand these issues. You can also perpetuate stereotypes that are related to these issues. We also found, and this is something that has kind of been studied in the literature, that as medical students course through their education, there's a decrease in compassion for their patients, and especially during the clinical years, especially times spent grading the other hospitals, we find that while students might enter medical school having more interest in these areas. So whether it's kind of the environment or whatever, there's a decreased sort of sense of compassion that is within students as they go through school. And this is just a study that kind of highlights that as well. It's kind of a national trend, kind of looking at medical students as they go through, just showing that there's less care, and if there's actually education focused on these social factors, that could possibly temper some of this decreased compassion that happens as people graduate and become residents.
So I'm Marie. And so what we wanted to do is look at what can we do. The literature says this is true, our results say this is true. What can we do at Emory to make this part of the curriculum and really institute a culture of discussing social medicine, living social medicine. So what we wanted a group of students along with us are kind of nudging the existing curriculum. So a lot of the pushback we had, there's set time during the curriculum, and there isn't much ability to expand it to social. So what we want to do is look at existing structures, like there's plenty of doctor curriculum, or the evidence-based medicine curriculum, and really introducing something about what is race. When you say African Americans are disproportionately this, what exactly is that? And having more diverse patients come in for our patients. During preclinical years, this is really a source for the students to be exposed to a wide variety of patients. What we've noticed is a certain demographic that comes in, wealthier, not necessarily underserved patients, and so adding more diversity in those patients. Another opportunity we have is to introduce a speaker series or a journal club to really have something extracurricular because there's not that time. And a movement that has started recently out of the Black Lives Matter movement is this White Coats for Black Lives. And it's a movement throughout medical schools in the country to really push for a creation of links between social justice and medicine, seeing that a lot of the same issues that affect social justice issues, a wide variety of things, is incorporated into medicine because, as Natalie said, medical care is such a small part of the pie. We have to address these other issues in order to really promote health in a lot of things. So another thing that we did is look at other institutions around the country. And one of the schools that does it most comprehensively is the University of Chicago. And they have a program that started in 2006, Healthcare Disparities, was a week-long immersion program where students would have course assignments during the day, and then they would also be able to visit the south side of Chicago, which is mostly minority, mostly underserved, and visit clinics there, and also visit the ED departments there, and to have conversations with patients. And within 2 years, this optional week-long program became standard part of it. It became required for the students, and now it actually crosses through the first quarter and goes from August to October. It really is playing on this concept of introducing students to concepts of social determinants of health prior to entering. And what they've even done further to build on that is this physician patient society system course, and it looks at social contact of medicine in American healthcare. So it talks about things that are American healthcare, Medicaid, Medicare, and really introduces them to the history of those organizations and also how our healthcare system now serves some people very well and others are have to resort to safety net hospitals. And another thing that they do really great, and so the Physician Patient Society system is a course that runs from October, the previous course, through December. And then human behavior and health and illness goes to this idea that they were both talking about how different people understand illness differently. And that plays into how they take your advice. how they follow their So Erin and I were on our social medicine elective last month, and for our private, and we decided to start this pre-orientation program with the objectives of helping students prior to starting anything in medical school, an optional program similar to in Chicago that helps them identify their personal and societal privileges and also develop this awareness of their own biases, how what they bring to a clinical encounter affects not only their patient, but themselves as well. And also to learn and interact with the social environment in Atlanta. There are many students who come to Emory from outside of the Atlanta area and don't understand how to create well and different histories of Atlanta. So that is something that is one of the goals of the different experiences to privilege doing a neighborhood inventory, sending them to Clarkson, for instance, and saying, okay, let's take a picture of how many grocery stores there are, how many corner stores, how many liquor stores. When you tell your patient, eat healthier, eat better fruits and vegetables in their environment, is that possible? So helping connect what they will do and promote as clinicians with what their realities are. Also, small group instruction and dialogue. Navigating Atlanta public transportation. The MARTA system is terrible. And when a patient has to take time off to go to follow up, you say, come back, follow up in a month. Well, we already took the whole day off to get themselves because of MARTA. How does that really play into your recommendations? And also through this program, we're hoping to build partnership opportunities and different organizations that will offer and have better resources for our patients. The progress on this, we've met with one of the med school teams and we have to go ahead and really now it's how do we build a program that's really intentional and really meets all of these objectives that we set forth. So ideally, so that's in the short term. Ideally, we would love to have some sort of Chicago longitudinal integration with social medicine concepts, so that it's not awkward for you to have a conversation about race. Students, yeah. And so it's something that students really are able to be open about, challenge each other on, and to really ultimately help the patients. And one of the quotes, I wasn't able to pull it on here, but it's from Harvard Medical School, which also does a really great job of social medicine instruction. And it said, regardless of where you enter practice, you will have political, social, socioeconomic factors that affect your recommendations and your health. So it's really important that us as students and future healthcare providers are exposed to that early and often.
So congratulations on pushing it forward to start it. Will this only be for pre-clinical students, like you're saying, or now that this is going to be an option, could students already in the clinical years take part of this as well?
So right now we would love to, our plan is to pilot it for a small group. So we really see how it builds on itself. There are other students, first year students right now who are working more on the aspect of incorporating this into the curriculum. So what we're hoping is to really start this off and based on feedback from students and also from administrators to really move forward. But from what we've seen, they're very receptive to it.
I think also too for students that wouldn't participate in the pre-orientation program, something that we really envision, kind of going back to the journal club that we were talking about, maybe not always like a journal article, but something that would be extracurricular, so it wouldn't be, at least at this point, required, but giving spaces for students to talk about these issues. I think something that I've learned kind of with the survey and also the
the sort of small groups that we held is that there's a lot of people in medical school that have similar sentiments, and so you don't really know who these people are until you just happen to be together with them, whether that's in a meeting like this or even if you're on a rotation with them. So I think something that will come out of this is having a lot of informal spaces that allow these conversations to be had, and hopefully by kind of increasing that, it will slowly become more a part of the official curriculum at Emory.
And I think I'd say for that too, say even I was in rear rounding and there was an issue that came up with a patient where it wasn't even my patient, but I wanted to advocate for him in a certain way. And it's hard to know how to do that, right? So I think that, you know, we want to have opportunities to learn more, but also, you know, you're in a hierarchy in medicine. So when you want to advocate for your patient in this way, you want to think about structurally, what are the best ways to do that within that hierarchy without, you know, making anyone angry at you or making it sound like you're, you know, or even without feeling like you're being judgmental, because it's hard to feel like other, you know, if you're feeling like people don't care about their patients, it's not necessarily true, just because they aren't seeing what you're seeing. But how can we all help each other see everything better as we go through the curriculum, and how can we better be what can we do as medical students? And I think that's something that would be great to have space for.
Thank you guys for starting this. It's kind of previously overdue at Emory. The story that was kind of constructing in my head when I was thinking about like comfort levels in the post-clinical students actually declining. Is that we go to training and then we realize how inadequate our training is in picking up. But we happen to be in rooms full of Mercer and a few more house students. And I was wondering if we open it up a little bit to find out what other schools are doing in the Atlanta area and in Georgia, like Georgia. I know, like Morehouse has more development right there.
And I know the Mercer students I was having, and I'm sorry if your names, the Mercer students in the back who did the project, the public health department, we're talking about the impact that that had on them. I think that'd be great to hear about as well. Anyone want to say anything? Well, I think if we're doing posters, or I know like that, I was talking to students who did the public health, who work with the public health department, do a quality improvement study on wait times, and they were talking about how striking, how much time they're, I don't know if you want to talk about yourself. So, but yeah, how striking it was to have, like, how much wait time people were having because of the systems there, and how striking it was for them to recognize what it is to go to a clinic and wait for 5 hours because they were there watching people do it. And so one of the things we talked about is, you know, you should have to go to Brady, like, to a pharmacy pickup or a clinic appointment. You can't help anyone. You can't use your knowledge or your white coat to help anyone. You just have to watch them go through and see how slow and frustrating it can be. And like, what would that do to a medical student in terms of, you know, learning that structural system and having some humility about how difficult it is for our patients. Anyone want to talk about your experiences at Morehouse?
Did you guys talk to Morehouse students about what their curriculum looks like?
I know they have, for their
Like their first and second years, they actually have sort of a community health track, and so all the students are required to do a community health project. And so I know one of my friends, she's doing, she's working at the Boy and Girls Club, and so she's doing sort of a class with like young girls in like self-esteem and nutrition, that sort of thing. But they kind of design their own project. And I mean, the Morehouse in general, I think their mission is very explicit towards that, but they do a lot within the official curriculum that supports students wanting to proceed with those sort of projects, which is awesome.
Is it pretty sorry?
Yeah.
Yeah, she's actually my big sis.
Oh, okay.
Yeah. Well, I actually work for the Boys and Girls Club, and we do have community health course, which she's it's during her first year. You can choose to do an honors program, which is what she's doing for her first and second years, and she'll get recognized for that at graduation. But aside from that, in fundamentals medicine, we do have a lot of focus on the other cultures and being more culturally aware and sensitive to others.
When we were doing our initial search of other schools, a lot of the things we heard was that you don't want to just make it something that is extra work for people. So you want to make sure it can be just a small group, not too much lectures. You want to make sure it's small group based. You want to make sure it's going to be like a TED Talk and not another article you have to read. And that some kind of community service or immersion in communities is important. And those are kind of some of the lessons we learned of the good places to start.
I don't know how how much input you guys want about our curriculum or anything. My name is Jen. I'm a second year at Mercer, and we actually have a longitudinal program at Mercer called Community Medicine. I think we're one of the only med schools in the country that has a physical department dedicated to community medicine. And basically what you do is your first year, I think it's 2 weeks in March-ish, so it's like right between hematology and neurology. We go out to an underserved, like a medically underserved county somewhere in Georgia. And I think they try to space it out so that there's no more than 2 medical students in each county. And you're with a community health preceptor physician, but they're all primary care physicians. You shadow them, but your first year is more about the community needs assessment. So you go out and you meet with like the Chamber of Commerce or the health department, or some people have even gone to jails. It's just like certain community places where there's big healthcare disparity or different needs in the community. So you do that for 2 weeks. You gather your community needs. You do a little paper on it. And then at the end of our second year, we're going to go back for a month this summer. And you sort of expand on that project and you do a little bit more, you meet with more people. It's more of a clinical role between second and third year, and then you spend another month in the same community fourth year. So it's a longitudinal project assessing the needs of the community. Like I'm in Cartersville, I'm stationed in Cartersville, and our top disparities are TIC, drug use. I can't remember the other piece right now, but that's basically what we focus on. And then your fourth year, you do a presentation to those same community leaders about how they manage some of those disparities. So we do have that, and I think as medical students, sometimes we look at it and just say, oh, there's so much studying to do, this takes so much time. But because it is built into our curriculum, you have no choice and you have to do it. And I think we all get a lot out of it.
We also follow a family with like chronic health problems and also a family with barrier to health care, whether that's not having insurance or whatever they identify. And so we'll be following them over 4 years basically to try to see how their situations change, what additional barriers they have or anything they overcome.
Can I ask, how do you follow them? Like, what does it mean to follow them?
So the first year we did interviews with them. So second year, I'm not really sure. They are probably going to sit down actually next week. But I know as part of the final project, I think in fourth year we're supposed to implement something in these communities to try to help, one of the situations that these families are facing, one of the barriers the community has with it. It's like transportation or most of them have like a public health department, but any sort of barriers they have to get there.
So, I mean, I know we've given up a really beautiful day, so we have this work for a long time. We have an abundance of people with food and time, and you want to stick around. Definitely encourage you to go to the professor's again. But a couple things. Thank you so much, first of all, for coming. It's the big thing. Second of all, I'm going to send out a survey in a couple days about things that we can do differently, better. Please feel free to take that time, or just email me. If there's something you think of, you have my email. We want to make this better. Reach more schools, anything you can think of, please just send an email. Also, I know we missed one of our speakers here had car trouble. Another thing we take for granted probably is our cars. And so I'm gonna reach out to him and see what stuff he can give me to send out to you, because I know I was really interested in that talk, and there's a lot we can learn from that, so I'll be in touch with that. And again, I just want to thank you. I mean, this is my third Health Stat symposium, and I think every time I get like a little disheartened when I hear about it's 2015 and look how many health inequities there are. But more than that, I mean, I think I take away a sense of excitement and pride that there are people who are so young and not complacent in their own lack of knowledge and abilities, and sort of these inequities in our state, in our world. So I think that's really exciting, and I look forward to everything you guys are going to do, that you're already doing. So thank you so much. And again, if there's anything at all, please contact me. Is there anything from the Health Staff Board that you want to announce? We have some really awesome things coming up.
I just want to reiterate what Jenny said this morning. If you guys are interested in staying involved with Health Stat or getting some more information about our programming, please reach out.
Halsted members, can you raise your hands again? These are the people to talk to. We have lots of opportunities to get involved, and we have an awesome board of directors with some great potential for leadership. So we would love to have that conversation.
And particularly if you are not on our email list and would like to be, please make sure you give me your email address and I would be happy to add you to the list.
I just wanted to say thank you, Ashley.
That wasn't me, that was them.
Thank you all.
Thank you, that was great. Thanks. We have plenty of food and time.
Please take some food.
Take
food. We have bags.
Got left.